Mohammed, Hussein and John Prashar, and so I'm aware of those. And I think, unless anyone wants to correct me, I think other than those two, we've actually got a full house of directors again at our board meeting. So that's absolutely terrific. Great stuff. Plenty of business to get through. We may have been helped by the fact that we ran the regulation committee just a week ago. So it may be that some of the things that we're dealing with achieved appropriate scrutiny at that point, but we'll see. And given that we have, and we warmly welcome guests, I won't go through the agenda just yet to remind people what we're going to be talking about, but that's we can do that once we've heard from our colleagues. I do want to just see whether I got a note that Caroline Chapman might be joining us, one of our governors. Caroline, are you on the call? Don't see Caroline there yet. And I don't think her name's in my list of participants, but there's quite a few participants today. So, and Caroline, if you are there, do you want to say hello? So perhaps Caroline's not with us yet. That's fine, yeah. And I was also Stephanie Hattersley. Stephanie, I wonder if Stephanie's joining us.
Yes, I'm here. Morning, everyone.
Good morning, Stephanie. That's great. Well, a warm welcome to you, Stephanie. And if we could just record the fact that the directors welcome you to what will be, I think, your first board meeting, Stephanie. But just a reminder to colleagues that Stephanie is one of our Insight programme graduates. So that's the programme that seeks to identify local talent and bring them right up to speed in terms of non-executive work. And that's what Stephanie's going to be doing with us for the next 6 months. So great to have you with us, Stephanie. And I'm going to start, before we just turn to our CBU, Children's CBU, it's right that the board, I'm sure directors will join me in wishing hearty congratulations to Selina on her success in getting the chair's job at Derbyshire FT. But let's also remember that Selina has given certainly 6 years that I know about, and it may indeed be more, because Selina's always had an interest in local health. But 6 years as the non-exec director given to this trust, and she's a great friend of the trust. She will remain a great friend of the trust, which is a conversation I've had with Selina. So Selina, may I place on record our sincere thanks for everything you've done, our hearty congratulations on your appointment. Very well done, and thank you for everything you've done. We've learned so much from you, and you've actually shaped and guided the way we act often as non-executives. So great stuff. Selina, did you want to say a little word at what I think is your final board meeting with us?
Thank you, Max. I'm just very honoured to have been part of the Bradford family. And especially at the Trust. I think we've done some great work at the Trust, and certainly over the 6 years I've seen it change for the better. We are much more outward facing, we are much more partnership orientated, and I think our exec have been brilliant in embracing that change, and they've taken it forward, and I'm sure there's still lots more to go, but I think this last 18 months has really shown what we can do and really place ourselves as a leader, as an organisation, in the truest sense, as a collaborating partner and leader, rather than grudgingly. We were grudgingly the leader, and we were not always respected in the same way, which I think that has changed, and I think that's changed largely because of our exec team. And also the board's perspective on that bigger world. So I'm really honoured and pleased to have been part of that. I'm waiting to see what happens in the next leg of the journey, certainly because it's my home city and town, and I will be always, interested in what happens, mainly because I'm also, my family are users of the services that this organisation provides. So as a member of the public and a citizen, I shall continue to keep you on your toes, hopefully. And thank you for the friendship and the learning that I've gained from the Trust. And as I say, I will miss the organisation every time I go past. I will resist the urge to come in, but sometimes I perhaps will. So thank you, and I hope to see you all in the future. I'm not gone.
That's very well said, Selina. There's lots of smiles and some applause around the colleagues as well, just noting that. So that was a lovely summary, very well put. Delighted to endorse your evidence of improvements that you've seen in recent times, particularly, Selina. So that's absolutely great. But do take all the directors' best wishes into your new role, and we look forward to keeping in touch, Selina. So and sincerely, thank you from the board for everything you've done for certainly 6 years as a non-exec director. Great stuff. Okay, so with apologies to Children's Services CBU colleagues who've been waiting, I did just want to get some important things off the ground before we started. We'll come back to kind of things like declarations of interest and all that. So we've received the slides, thank you, and I've had the chance to look through them, and I'm excited by what we may indeed just be hearing now about the developments in this CBU and the desires and hopes for its coming months. So that's absolutely terrific. Saj, should I turn to you first and just ask if you wish to say anything by way of a word of introduction? And then perhaps, given that Helen's name's on the first slide, we could turn to Helen and invite her to lead the session. So, Saj, Chief Operating Officer.
Thank you, Max. Yeah, it's great to have the Children's CBU. So Helen's obviously the Clinical Director for the service. She's here with a number of her colleagues who I'll ask Helen to introduce at her point started. The Children's CBU have been phenomenal in terms of their support to the organisation throughout the COVID pandemic. And as you'll hear and learn their aspirations and their vision for their service, but also the pressure that they're currently under and are anticipating to be under as we go forward. So there's the real visionary stuff of where the service wants to get to, but the here and now operational pressure that the CBU is juggling at the same point in time. I felt it was really important for Helen and colleagues to come here and share their good work with board. So yeah, I'll hand over to Helen to quickly take us through. But like I say, if it could, Helen, if you could just do a quick intro for the colleagues who have joined you on the call today.
Thank you, Saj, and welcome, Helen and team.
Thank you, and many thanks for having us. It does seem a really timely day to come to be able to thank Selina as well for her support for Children's Services. So it's great timing. I apologise in advance. I'm going to be doing the talking today, and that's because it's actually a real challenge to in 15 minutes tell you the amount we want to tell you. But with me, we've got half of the people we wanted to have. We've got Rob as our manager, Sam Wallace, our specialty lead from the Neonatal Service. We've got Jamie, our matron from Community, Kirsty Haslam, our specialty lead from General Pediatrics, and Matt Matai, one of our paediatricians who is instrumental both in our ambulatory care and in our work with Bourne and Bradford. The other half of the team are pulling their sleeves up and on the ward at the minute and send their apologies, but it's a busy day. 15 minutes is going to be a challenge, but what I'm hoping to do is give you an overview of what we do. We know you're aware of quite a lot of the work, but we're really proud of a lot of things happening in Children's Services. So I'm going to try and let you know a bit about the children's needs, how we're trying to meet those needs, mention a few of the things we're proud of, and a focus on the challenges that are coming up very soon, but also then leave you with our vision for where we want to go and where we would like your support in going. So children in Bradford. I don't need to tell you this. Next slide, please, Jamie. Thank you. Bradford's one of the youngest cities in the UK. It's the 4th highest proportion of under 16-year-olds in England, and we really need to give these children the service they need, because not only have we got a lot of children, we've got one of the highest child poverty rates, 30% in comparison to 15% living in absolute low-income families. But we also know from the Bourne and Bradford data that we've got double the rate of congenital anomaly. And the graph at the bottom shows our infant mortality rates. Our childhood mortality rates are the same. The blue line is Bradford. Despite a lot of effort from the whole system, our mortality rates are still significantly above both England and Yorkshire. And that really represents our population. Latest data showed that we've got the highest prevalence in Yorkshire and one of the highest prevalences in the UK of children with life-limiting conditions, 1,607 children. That's phenomenal, and it really just details what services we need here in Bradford. They account for a lot of our flow as well, 20% of children coming through ED. We like to keep you all busy. So what's our vision? Our vision really, we've heard about happy, healthy and at home, and that's great because as well as working for Actors One, it works for our children. We want to be child and family focused. We want to give care as close to home as we can, whether that is in Bradford Hospital instead of Leeds, where it's appropriate clinically, but also at home where that's possible. And we can only do that by working in partnership, by using the right people in the right place at the right time, and working in partnership not just with our colleagues, but also with the families. And it's got to be really well coordinated care to do this well. So we like to say we're a hospital in a hospital, and I'm going to try and demonstrate that to you over the next few slides. So when we talk about children's, we've got Neonatal Services, Child Development Centre, Community and General Pediatric and Specialties. So I'm going to relatively quickly talk you through what we cover because it really is quite wide and it definitely keeps us on our toes. So starting chronologically with our neonatal services, I was delighted to find a picture of Jamie to embarrass him there from one of the media publications. But we're really proud to have one of the 4 neonatal intensive care units from Yorkshire based here in Bradford. And we provide level 3 care for premature infants as young as 22 weeks gestation. And I always like to tell people, you know, we look after babies as small as 400 grams. Imagine your bag of sugar. And that's what our colleagues are doing. And places like Leeds inevitably specialise in surgery. Our team are striving to be outstanding for the premature and the low birth weight children. And that's really important. I think our team has got a really exciting few years coming up. That they're looking at how can we meet the Bradford population needs, and we've got a phenomenal innovative palliative care pathway that's really small and almost a pilot still at present, but we call this the butterfly pathway. And a neonatologist links with a mother when she has an antenatal diagnosis of a life-limiting condition. The phenomenal quality and difference it makes to the families of having that face right from the beginning of pregnancy. We see an impact with a reduction of the amount of times they come to the ward, and they are far less likely to be ventilated. I believe none of the children that have had this care have been to PICU because they then trust the advice and they trust the clinician. And there are so many things like this that that the team are trying to do, but also that we can really expand on. I think we've got an exciting time. So moving on from neonatal services to the general pediatrics, our hospital within a hospital. So at the bottom, it's a busy slide with apologies, but we've got our inpatient services. We've got our brilliant ward on 30 and 32. Thank you so much for your support in getting onto that new ward. Without that, we would not be managing at the moment. So we have a 41-bed ward with some really good enhanced care cubicles with glass fronts so we can provide optimal care. When I wrote these slides, we had 2 stabilisation beds. We've now got 3 because we're working rapidly. And we have an isolation cubicle that was great for when we just had 1 COVID case. And we're now innovating to keep those children separate. We've then got a day case unit. And again, massive thanks for supporting us in moving that up to 12 to make our children's wing. It's got an elective surgical unit. It's also got a day case haematology unit for these children who every 3 weeks have to come in for a transfusion. It makes so much difference to them to have a good unit. We have the plastics clinics there. We hold our safeguarding assessments. And our new innovation is the Children's Ambulatory Care Hub, which I'll speak about in a moment. So we've talked about children being at home at the top of the slide, and we really try and keep them there where possible. So we have our clinical decision area on the left where we keep children turning over at a really fast pace with assessment cubicles and short stay beds, really trying to get children out, even if it's at 10 at night, 5 in the morning. They must be at home as soon as it is right for them to be there. And our ambulatory care hub is a really small pilot at the minute, seeing what can we do if we have a consultant at the front door giving support and advice to GP, working with our award-winning ACE team, our ambulatory care experience team, when can nurses look after children at home? And then also giving advice and guidance and using a rapid access outpatient review where that's more appropriate than a ward attendance. And really, I've just highlighted there are a lot of different routes for children to come into us. And whenever they come to PEDS-ED and GPs, it's, are you really right to come to the ward, or can we offer you a different service? But equally, those children that are really complex, we offer them direct access. We don't want GPs and A&E to be struggling with really complicated families. Those families self-refer to us. We then have got to focus on happy, healthy and at home. And I've already mentioned our ambulatory care pathways. We're just about to launch all of our antibiotic at home pathways, which we're really excited about. We've also got a paediatric respiratory outpatient service. These children would previously need to come to the ward for 2 weeks at a time, several times a year. We've managed to move that to outpatients. Our aspiration is to get that at home. We have a children's community nursing team who look after 31 children with significant needs, whether that's ventilation or tracheostomy. To put that into perspective, there's one in York, I think a couple in Mid-Yorks. I believe we have more than Leeds. And these children at the minute, their services are all in Leeds, and that's one of our aspirations for the future. And we have a phenomenal palliative care team. You've already heard about the need there. We have a really small team. There is work ongoing to try and expand it, but for what the resource they have, it's phenomenal for how they keep these children at home. Next slide, please. And then outpatients. So I think everybody knows we have General Pediatrics and rapid access clinics. But actually, we have far more than that, and it really keeps us on our toes. We have all of these specialties. The left side of the slide are all run by our consultants, and every one of these services is brilliant. We have phenomenal clinicians working here. They're small teams, so resilience is difficult. Every team links in with leads when needed. And every team has external scrutiny in the same way as adult services. So our diabetes external review, our peer review for haematology. It is a real challenge to keep every service moving forward in the way that they need to. And in addition, it's absolutely right that we have these outreach clinics, but we have clinicians coming from Leeds, from Manchester, from Newcastle, coming to offer these outreach clinics because the numbers of children needing these services are so significant in Bradford. And again, that is a massive opportunity. There's a bit of Jenga going on with the paediatric outpatient rooms, how we coordinate all these, because, well, it's entertaining, but we're really proud of these services that we offer. The next slide, please. Child Development Centre, I've put last, but it's a real plea that it definitely isn't least. The needs for these guys is really, really massive. Under the umbrella of the Child Development Centre and Community Paediatrics, we have all of these services. I think you will all be aware of the challenges for child looked after, for children with autism and the numbers coming through. But in addition to this, we have 54 children with spina bifida. We're the only place I know that needs a specialised service for spina bifida. We have a specialist trisomy 21 clinic, specialist neuromuscular clinics, massive complex neurodisability. Our continence service has one of the greatest needs. It does have the greatest need in Yorkshire, but is one of the smallest services. So these guys are really working their socks off to deliver a good quality service. And I think it'd be fair to say I worry about the postcode lottery of what our children are getting in comparison to children in other areas. The graph there is the number of education healthcare plans, and I've used that because it just indicates the number of children that are needing some sort of medical support in this area. And you can see the growth over the last decade. The planned growth is even greater than this. And I think that really represents the need on this service that hasn't changed over the last decade. But I really want to emphasise that despite all that, the photo below is from our toy library, which sadly is closed at the minute due to COVID. But our staff really work hard to give these families and patients a really good opportunity, really good care. And there's some great things happening out in the community. And it wouldn't be right without adding our wraparound services. We're really proud of our education. I love teasing Becky Bargett, who does superb teaching. She is nominated regularly for the Inspirational Teacher of the Year award, and it's great teasing her about it. Our safeguarding team are brilliant. Safeguarding is really difficult and challenging, more so than ever, and they are phenomenal with the advice and support they give. Research, I think we've always been good in neonates, but we're seeing opportunities in peds that we're finally managing to work out how to try and take those. And so it's going to be exciting in the next 3 years, I think, for research. Transition. Every child that we look after has to transition to adult services well, or we haven't done our job well. And there is a real challenge in that because it's difficult. And it also involves linking in with every single adult service. And obviously those adult services have got their own challenges and focus. And so that is an area we're trying to be innovative with. We're trying to meet standards for, and we will keep working at it and bring you really good news, I hope, in a couple of years. CAMS doesn't sit under us, but it wouldn't be right not to mention it because of the amount we rely on them and how closely we're trying to work with them. There's been great progress with daily huddles. We have one of the hardest children I've ever had to look after on our ward at the moment, and the support that CAMS have given us over the last few weeks, as well as the executive team, is phenomenal. And palliative care I've mentioned, and yeah, I can't emphasise enough, they're a brilliant team. Next slide, please. So COVID, it's been a funny old year, hasn't it? There was a cartoon in one of the papers about the paediatrician in COVID, and it had a paediatrician swinging on a swing with buildings burning down in the background. And that possibly does reflect the first couple of weeks of COVID. It went really, really quiet on the ward, and it felt really eerie because we'd ramped up everything and we sat there thinking, well, what's going on? But actually, because children weren't mixing, our numbers dropped overall. The mortality rate for children dropped last year. Really low numbers of children were affected. And then things started getting interesting. A new condition emerged, PIMS-T, and it was so exciting being on webinars and learning about this condition in real time and listening to people in Boston and in London. Slightly daunting for me when I learned that these children were all going to need an echo daily or twice daily. So there's just been an interesting year. But then safeguarding got harder and the number of cases came and they were more significant. And the CAMS patients, I say, have been so challenging for the staff to look after and so distressing for these young people. Our staff don't like to be quiet, and I'm really proud of our staff on the wards and from community. And I think I'm really grateful that they were offered the Chief Nurse Silver Award. And I know it went to 3 individuals, but I think that represents the whole of our team. They went, despite paediatric skills, to the adult wards. They went to immunising, they supported visiting on ICU, and they were just phenomenal. The medics as well helped where they could, supporting on adult wards. I went onto an adult ward for the first time in 21 years, and it was terrifying, but we tried. And we started planning for winter surge, and I'm so grateful that we did that. It felt really strange when it was quiet, but actually I'm glad that we did that. And there were benefits. Our telemedicine improved. We started using a device called Tyto to try where you can see pictures and you can hear children's hearts from being at home. We had really good ties with PEDS-ED, and if I was to name one benefit, I think that's been phenomenal. And we got our new paediatric wing with Ward 12. And I think our relationships across the trust with people have really come on, and that's fantastic. Next slide, please. So where do we go from now? So I implied that I was pleased about our winter planning, and I'm going to have to rename it. It's surge planning because it's not winter, but children have started mixing and RSV is here. So RSV is the children's version of flu. It accounts for, I think, 148,000 of GP attendances annually, but also it's something like 98,000 across the UK in inpatient admissions. And we've been asked to prepare for up to a 20 to 50% increase in RSV cases. This is based on modelling data from Australia. Some of the modelling went up to a doubling. But either way, the implications for this are massive for us, for ICU, for the ward, for ED, for GPs, for parents. And so we've been trying to get on top of this. How do we optimise our ambulatory care? I talked about the silver lining of COVID. The silver lining of the children's version of COVID, I think, is going to be better links with primary care. It has to be. And there are some real opportunities emerging there. And also working across WIAT, working with the urgent emergency care pathways. Everything we wanted to do in 2 years, we seem to be trying to do in 2 months now. So I will hopefully feed back next year with some really good things. And I think for us, we're really trying to increase our palliative care presence on the ward as well. We don't want children to be going to intensive care if it isn't in their best interest, particularly when that resource is at a premium. Next slide, please. So strategy and vision. I'm going to say a little bit about each area and then just end on our vision overall. But neonatal service, I said we want to be an outstanding unit with a focus on quality, making sure that every member of the team feel able to contribute to that journey and work together. There's some really innovative work, and I think our next focus, there's a bit on meeting the staffing requirements just from some national guidance, but actually there's some really innovative, exciting work about allied health professionals as well that we really can have. It's a really excellent opportunity. General Pediatrics, it's really going to be based about this next winter and how we get through it. but then a bit of a deep breath. And what do we do for these children with long-term vent? What's right for children in Bradford for a level 2 service? We must succession plan for respiratory and diabetes. They're two major not to do that. And there are some opportunities. I've put infection control instead of infectious disease. That's showing what I was thinking about when I wrote the slides, but there are opportunities there. And CDC, I end on it not because it's least important, but because it's the most exciting. It needs to be a complete modelling of the service needs and an innovative new model. How can we use what we've got? How can we develop it? How can we alter the environment and the estate to work for these children better? Last slide, please, Jamie. And so really, when I summarise overall, we've got such excellent opportunities with the Born in Bradford data. How can we work with the Born in Bradford data to determine our service need? You might have seen Matt leading a session for the college on looking at vulnerability. How can we identify our vulnerability? How can we make sure we're meeting those needs? How can we be a voice for our children and young people? And if I was to say one thing, let's develop our youth forum. We've got a real opportunity here, so we know what the children and young people need and want. Can you advance, please? How do we work in partnership? We need to work with YAT, act as one, and it's such an opportunity for us to move things on. I've really benefited. I've been meeting with head teachers. The support we get from them is great. CAM, social care, all of these areas, I think will help us, along with your support, to become a voice for our children and young people. And so really that is the thanks for your support so far, and the plea. I think together we really need to articulate the needs for these guys, and we're appreciative of your support there. Any questions, please?
Fantastic, Helen. Thank you very much indeed. That was great. It's right, as chairman, of course, that the first thing I should do is thank you and your colleagues for joining us, for the courtesy of preparing such a useful slide pack for such an excellent presentation. And in some sense, of course, how disappointed it is, how difficult it is for the wider board at the moment, of course, to get to know you better. And that's why we're really grateful for you coming here. Our normal walk rounds of visits and things are obviously hindered significantly just at the moment. And this was the idea of just getting to know the CBUs better. And it's, Helen, just to share with you and your colleagues, it's in the spirit and the context of being genuinely inquisitive. You know, there's no intention to sort of, nobody's trying to check anything here. You know, we're a board of directors responsible for this hospital, of course, for doing what we should do in accordance with our constitution. And this is purely a supportive context and genuinely interested in what's the business in children's services, you know. So absolutely terrific. If I may say, I'll open up for questions now, but if I may say, I was absolutely delighted with that presentation, and great to hear you using the language of becoming outstanding in certain areas that you want to really focus on, but also that you finished beautifully on the idea of wider partnership, and that everything we do is in the context of how it impacts on the wider health system throughout Bradford and beyond, indeed. So it was great to hear you thinking like that. So Helen, thank you very much. I found that extremely useful. I'll open up for any open questions now. And of course, Helen, perhaps if you direct the questions to who you would wish to as appropriate, but we'll perhaps look at you first. And I'll go in accordance with the hands raised. So, Ray, would you like to come in first, please?
Thanks, Max. So not a question, just a comment, really. My experience of children's services were very limited before I came into this role. But over the last 6 months, everything I've seen from the CBU for Children's Services has been the model of how a CBU should operate. I think being able to carry on the business as usual, whilst at the same time being innovative and planning for what's coming, so the tsunami of RSV infections has been hugely impressive. I think the engagement, the teamwork, the just willingness to roll the sleeves up and get on with it has been hugely impressive. Helen quite rightly and understandably focused on some of the work that they're doing and some of the team members, but I'd also like to just focus on Helen. I think as a leader, she's been absolutely outstanding. I think she does have a wider role as well within YAT as paediatric lead there, so she has that wider responsibility as well, which gives her the oversight. So to Helen and Sam and the rest of the leadership team, thank you for being such model examples of how clinical leaders should be. So yeah, that's just wanted to add that in. Thank you.
Very well said, Ray. Thank you. And that's great to hear our medical director speaking like that. So thank you about this particular area. Selina, may I bring you in, please?
Thank you, Helen. Having sat with you a number of times, I know how hard you work and how hard the team works. And it's brilliant to see this really comprehensive presentation on children's services. And for me, I suppose the question is, you highlighted the complexity of and the nature of the work that you're doing, and there's so many interdependencies with other parts of the system and within the organisation and so on. What can we as a board do to help you? What keeps you awake at night, and what can we do to assist you? So that would be my ask of you, really.
You might have seen some laughing. I can honestly say in the last 2 weeks, there's probably been 6 nights that we've been awake at night. I'm really keen to hand questions out, but this one I'm going to keep because it covers all areas. I think we already have a lot of what we need, in that every time something comes up, I'm able to come to a member of the exec team and I know that I will get support, and that I can't emphasize enough how grateful I am for that. If I was to look at 2 of the nights, I know Kay, who's joined me, will have been up as well. CAMHS patients, I think of the unsolved group. I can see progress in all the other areas and I know how to move forward. CAMHS patients, I can see getting worse. And so I think it's on that relationship and support for our colleagues in CAMHS, because they're genuinely, these children are stuck. It's not that people aren't caring or trying, it's that the service isn't there. So I think it's by being a voice when we need it. And the 2 voices at the minute, one is about CAMHS patients. There is the safeguarding as well. The other is with regards to surge. I genuinely believe that it's being led nationally, because it's hit the north before the south. The national support and the national comms isn't coming out yet. And I think I've got so much support in the last 2 weeks for Ped Surge, but it's that sort of level of voice that we really need. Is there anything anyone would like to add?
No, I think you've said that. I think they're our main key issues. Yeah.
But a thank you, because almost weekly I think of something, and it's great that I can pick up the phone every week.
That's good to know. Thank you, Helen.
Can I just jump in very quickly? Sorry to interrupt.
Of course. Yeah.
Just to echo what Helen said there, and I think it's probably very timely that you asked that question, Selina, given that Helen and I and Kay were in contact at about 9:30 last night, trying to when I would have much rather been going to bed, but the question of sleepless nights, does happen fairly often. I think it's a reflection on the complexity of the patch and the risk that we hold within the CBU. And I think we've done a good job in describing that better over the recent past to our exec colleagues, and it's been really well received, as Helen's described, and whenever we've needed that response, it's been forthcoming. But it does show, and hopefully you've seen from the slides and the way Helen's presented, just exactly how much we've got going on across our services.
Yeah, and I suppose we keep asking you to give more and more, and we can't clone you, unfortunately. So what do we do? How do we create some additional capacity so that you can do that complex work and carry on, staying up at night consecutively and that kind of thing?
Great stuff.
I really value that. One of the conversations we had with Saj recently was actually we'd value a look at how we link in if there are any further management restructures within the trust, because I think it is so complex. There have been lots of benefits from the planned and unplanned care, but we sort of sit between the two. And I think looking at our management structure and the resource might mean we can keep all areas moving forward. But we have support for that, and that's one of the reasons that, yeah, it's been great knowing that each area we can look at as we move forward.
Great stuff. Great stuff. Selena, thank you, because you set the tone beautifully there, actually, to remind our CBU colleagues and us all as a board that there's nothing we don't want to hear. Of course, it's difficult sometimes to deliver everything that everybody would like to, but we do want a situation where people feel, I can at least speak about this and raise this issue. So that was a great question and very well answered, Helen and Rob. Thank you. Thanks, Selena. Altaf, I'll turn to you now. Thank you.
Hi, Helen. Helen, thank you very much for an excellent presentation and some great work from you and your team. Much of what I wanted to ask was, I think, it overlaps with Selena, but I'll just make a point regarding wider partnerships. I mean, you touched on basically, I suppose, early intervention and prevention is key, and you've got the right demographic for that and the data from Born in Bradford. I mean, in terms of early engagement with other actors like parents, education and primary healthcare, is there more that can be done in terms of providing you with the resource, whether that's human resource or access to other stakeholders in children's healthcare, that we could do better?
Matt, would you like to take this one?
Good morning, Matt.
Hi, no, thanks for that question, and thanks, Helen. First of all, I just want to agree with all of the comments previously. I think Helen's an absolutely amazing leader of our team, and yeah, leads very much by example. In terms of the issues that Helen highlighted, a lot of them are wicked problems. So I'm a diabetologist, and type 2 diabetes is one of my areas of interest. We face lots of complex problems in Bradford, and I think we can't solve it in the trust. We have to be working with partners outside of the trust. I think certainly with my recent involvement with Born in Bradford, I think one of the key partners are going to be schools going forward. I think there's a huge opportunity to work with schools to improve health. That's where children go most of the week, and it's where parents come to drop their children off. So I think certainly sort of improved links between us and schools will be key. I think improved links with also the voluntary sector and with primary care. We've been very fortunate just to get a successful bid for a platform called the Healthier Together programme. And I really believe that it's almost a £500,000 investment by NHS Digital over the next 3 years to develop this programme. And I think that, together with the data from Born in Bradford and with the links already established through the BID programme, can really make significant inroads into community where we can tackle some of these wicked issues. So we're starting to work and move down this route, but it's only going to be done through partnership, as previously mentioned.
Thank you, Matt. Thank you. Altaf, was there anything further, or did that satisfy your query? Thanks.
Yeah, it does, and it's very kind of reassuring to hear that work is being done, especially with chronic illnesses like diabetes, which are expensive, I suppose, in the long term to manage. Just a quick point, as part of those actors that you're reaching out to, is there a program to reach out to the food industry as well? Because I'm always shocked at how easy it is in Bradford to go out to a takeaway and buy the wrong foods for very little.
Yeah, it's a really good question. I think, again, just going to the Born in Bradford programme and John Wright's role currently in the local authority. So he's obviously got obviously the trust link. He's also got lots of links in the community, and also as part of the local authority, I think, exec team as well. And I think for the first time, we're able to actually link all these major players. And I think part of the approach of BIB for a citywide co-laboratory is to actually influence local government to change the way they do things. And part of that is to look at certain areas in Bradford where there are, shall we say, sort of unhealthy options available, to see how we can influence that through health and local authority working together.
Thank you, Matt. Altaf, that's okay?
Yeah, that's perfect. Thank you very much, and carry on the great work.
Yeah, thank you. And Matt, my apologies if you're already entirely aware of this, but the Born in Bradford programme, actually through John, trying to create a new educational programme amongst our schools in order to raise awareness. I think particularly at the sort of end of primary school age, really raise awareness of health issues throughout the city. It's a really strong suggested programme where people from the team go in to schools and run sessions, and it's kind of all part of John's things about raising this idea of creating young citizen scientists locally. So I'm sure there will be crossovers there. And again, apologies if you already knew about that, but it looks a really exciting programme potentially. With I suggest possible great links to the Children's Services CBU. So, okay. Thank you. And I should just note, Helen, thank you that we note your point about the support for Child Development Centre development being really key. So that's in the chat there. Thank you. And our guest director, Stephanie, made an interesting point about whether discharge times, whether it's ever possible perhaps to consider those in the spirit of how easy it might be for particularly perhaps a deprived family to be able to collect and go home and get the transport. I can see that Ruth helpfully has answered that, but I don't know, Helen, if you wish to say any more about that challenging point.
I'd just love to provide some reassurance. We have some families who are desperate to get home as soon as they can. They're normally families who have difficulties with childcare at home. So for those families who are desperate to leave, we will facilitate that whenever it is appropriate clinically. What we normally do then is keep children moving for the night, get all of their paperwork done, let them wake up, have breakfast, and when they can be collected easily, get them home. Or if they're struggling to get home, work with the family to support them in that. We would never discharge someone at night that we were concerned made it difficult for the family. I guess I'll put a small caveat on that with the bed pressures. If somebody could easily leave at 7 in the morning and they don't seem to be worried, we would gratefully thank them for that. But no, I appreciate that was a good point.
Yeah, thank you, Helen, and thank you, Stephanie, for raising that useful point. That was great. Thank you very much. So, in the absence of further hands held up, may I just check with director colleagues when you reflected upon the future plans brought to our attention by the children's unit, were people comfortable with those? Did anybody want to raise anything that they hoped they may have seen there, for example, or did they have any issues relating to the suggested future plans and areas for priority? And if I don't hear anything, I'll assume people were comfortable and confident with those. But Mel, would you like to come in? Yeah.
Well, I need to say, Max, we've recently had a CBU to exec conversation with this team. In fact, in the newly launched approach that we are taking to those kind of structured conversations, this CBU went first, which I have to say is to the detriment of every other CBU that will follow, because they have set the bar so high, and reiterate all the points that Ray has made. So in those conversations, we cover sort of performance now, some of the issues, challenges and concerns, but also what the CBU feel are the priorities for the future. So we're fully sighted on what the CBU believe to be the right direction of travel for priorities in the future and concur with those.
That's actually really useful to know, Mel, from the CEO perspective. Thank you very much indeed. But as ever, I would just wanted to make sure that paused and give people a chance to say, should they wish to have raised anything related to that. Well, that's fantastic. So listen, Helen and team, and we do very much realise it's a team. Helen, you're the clinical director, but of course we know that you're dependent on colleagues and working together. And I realise that are triumvirate models, etc., So I'm comfortable with all that. But it's been fantastic that you've taken responsibility for chatting through with us today. What great insight. What a wonderful opportunity, actually, to take the best part of 3/4 of an hour to sit, to listen, to think about children's services. So absolutely fantastic. So a sincere thank you to you all and for everything you're doing, and with best wishes for success as you move forward in your future plans. And I'm going to just conclude on the assumption that I think we've dealt with everything we need to. We do retain chat, Helen, so we've got the chat box as well, so that can help in terms of making a record of this meeting and some of the very useful points that are sometimes briefly made on there. But I'm gonna pick on one of the members of the team because I have it on very good, a very reliable executive source that Jamie Steele was working rather late here last night, and indeed he's been thanked by one of our very senior executive directors, who points out that he was on site till very late last night and is back here for this morning to listen and to participate and be part of that. So I'm sure there are plenty of other thanks throughout all the people that are here now, but a special word to Jamie, who has been recognised as working late last night and back up this morning and part of our team. So there's a lot of smiles and appreciation, and I did want to just specially mention that. But you're a great team. You're making us proud. Thank you so much for. Well, I'm going to finish with this one. We're Bradford, so let's speak up for what we do well in Bradford. We perhaps haven't done that enough in the past, and it's a great team, a great innovative work, and it's wonderful to see you thinking about partnership, thinking about the wider system, and influencing that in the way that you know is right for children's health in our city. So, thanks very much, everybody. Julie, would you like to come in for the final point?
Yeah, it was just a comment that what's really useful for me is by listening to the CBUs is the kind of process how the CBUs work in the organisation and the kind of real link to our values, you know, one team. And I think we see in the CBU what a great team they are and how they work as a team. But we've also heard how they work as part of the bigger Bradford team, helping out when needed and working as part of the system. So I think these CBU coming to present to us really linked to the values of the organisation, and I just think that's really important for us all to hear and to understand.
Great point, Julie. Thanks very much indeed. So, colleagues, Helen and team, the board of directors sincerely thank you for the courtesy of your time today and for everything that you're doing. And you of course have our sincere support for everything that you're trying to achieve. So, thank you very much indeed. A really, really helpful insight, which will shape our thinking in the coming agenda items, I assure you. So thank you very much indeed. Okay. So thanks everyone, and what a great session. Terrific. Thank you very much indeed. Lovely insight. Yeah. Thank you, Helen and team.
Thank you.
So I'll let colleagues go that wish to leave the meeting. That's not to say that nobody can't sit in and listen to the rest of the board meeting, should they wish, of course, but I guess they will have better things to do probably that are waiting for them right now. So, yeah. Saj, that was great. I think these getting to know you CBU sessions are actually really, really helpful, if I may say so, perhaps particularly from a non-executive perspective, where we're finding it slightly difficult at the moment to engage with teams. So, yeah, that was terrific. And
we plan out just to highlight. So between Ray, Karen, myself, and other exec colleagues, we plan out a session of these meetings throughout. So we've obviously had crit care colleagues come. We've had elderly care come and present, and obviously today we've had children. So we try and give you a full range of the different clinical teams. But I think, as Julie just highlighted there, it really does bring home how all of these CBUs are interacting with each other to deliver the services they do, and the excellence we've got actually in terms of individuals like Helen Jepps out there who head up and lead our CBU structures.
Yeah, well said, Sergeant, and well said, Julie, because the point you made about being encouraged to hear CBUs talking the organisational language and the language of representing as well in the system and working as partners well, etc. It was really powerful. So, as well as, of course, living by our values. So, well said, Julie, and thank you, Saj. Yeah, great stuff. That's a terrific session. and very, very helpful insight. Okay, shall we get on with business then, as best we can? I do promise, of course, to pause for a break and let people get a quick leg stretch and relax for 5 minutes before we continue. However, shall we just go back to item number 2, please, and note that we now, of course, always table the declarations of interest that we may have. But of course, it's incumbent on me as chairman to remind you that if one arises during the course of a discussion, then do please raise that with me. And just to encourage director colleagues, there's no suggestion that things haven't been raised. It's simply that we're just getting on the ball in terms of our governance requirements there with the declaration. So that's what that's about. So that's section 1. We'll go into section 2. Well, I'll just say what the agenda items are intended to be. So having reviewed our minutes, we'll take reports from myself and from Mel. We'll deal with the report from the Regulation and Assurance Committee, which summarises everything we discussed there at section 4. And then we'll go into finance and performance. And in that, we've got, again, a terrific slide set. So look forward to hearing from Sarge about the elective recovery update position. We'll then go into quality, and we've 2 main items there, which is to think about the quality account and whether we're content to approve that. And as ever, it's a super document to actually take time to read. It really tells you a lot about what we do. And Ray will bring us up to date with research activity in the trust. And again, a terrific little slide pack there, Ray, that's been produced, which I think is worth celebrating. People will hear under Pat's command about Equality and Diversity Council update. That'll be Mel herself, of course, as leader of that. And then with an opportunity to think about the disability equality video and the strategic staffing review. I think Karen will just bring us up to date verbally on that issue. Under audit assurance, we'll give Barry the opportunity, of course, to advise us of anything he would wish to draw to our attention from that report at item 15. And then at item 16, with an opportunity to hear from John about progress and comment on the corporate strategy refresh update. And then I'll make sure that we try and give time to the governance items, because they do just require a little bit of attention giving, and I'm comfortable that they are properly written up and good suggestions. However, if people feel they haven't quite had the time to deal with those, then of course we can always pause and hold or whatever. So review standing orders, governance review update, and the request that we ratify the data security protection toolkit decision there. Okay. Can I check whether is there any other business that is not on the agenda that anybody would wish to lay down for discussion, please? No. So we can get through this significant agenda. We'll have done well, but B, that's great to know. Thanks very much indeed. So that's the intentions for the meeting. We'll try our best to finish that by 12:30 or before, and then I think we've got a short closed meeting to conclude board business today. So thank you, everybody. May I move to item 4, which is to ask whether the minutes of the meeting held on the 20th of May are an accurate record. And I should put on record my thanks to Selena for, I guess it's fairly short notice, Selena, picking up the duties of the chair. So thank you for running the meetings that happened that day while I laid in the LGI. Don't put that within the minutes, will you? But, that's where I was. So thank you very much, Selena. Yeah. Are the minutes a true record of the meeting, please? Are there any matters of inaccuracy or amendment that anybody's noted that they would wish to be changed? And I'm not seeing any hands or issues raised, so we will take those as a true record. Thanks very much. We just have some matters arising. If I could just draw you through, please, the 1, 2, 3, 4, 5, 6 actions. I think we've got good action on these, but let's just check. So the first one related to the learning from COVID report, and it was a suggestion that if there's any further comments or suggestions, they could go to Laura. Now, in the comments box there, Laura, it's just shown as action closed, but can I assume that you're happy that people knew they could contribute to that? And, well, did anybody, was there any issues of note that were raised with you, Laura?
Max, it's John here, because I'm handling the publication of that report. We had 1 or 2 comments. There was nothing substantive, but we did have a good discussion beforehand, so I'm not surprised. But we gave people a chance to contribute.
Thank you, John. Are you content the action's closed there, yeah?
Yeah.
Yeah, thank you very much. And in the absence of anybody objecting to that, in item 2, learning from the COVID report, the report was to include reference to permanent changes made by the organisation as a result of COVID. So I guess that was some feedback on that. There's a useful comment section there. But again, John, just from courtesy, I'll turn to you and ask whether, did you want to raise anything further with board colleagues?
No, nothing of substance. I think it was Selina's comment in the meeting, and we've made sure that the draft report really brings out the learning points. Every chapter ends with, you know, what we learnt, so it's more explicit, and it's in good shape. We expect to publish that soon, and thank you for all the input we've had.
No, that's great, and I have to say I'm pleased to see that particular part being included there as well. So thank you. Good point, Selina, and thank you, John. In the absence of any hands raised, I'll take that as closed as well. We'll go to the third action, which was the Equality and Diversity Council, the terrific work that that team are doing. And the suggestion was that there might be an offline discussion to be held regarding the links between that council and a piece of work on inclusive digital transformation. And Paul, it was suggested that you might pick that up or delegate it appropriately. So discussions, links between inclusive digital transformation and the work of DDC. Any opportunity for progress yet, Paul, on that, please?
Yeah, Max, I can update that I attended the last Equality and Diversity Council. Sorry for the verbiage about inclusive digital transformation, but it's become a term of art at the minute. So I did join the last Equality and Diversity Council. The conclusion was really twofold. One, that I should become a standard member of that group so that this topic continues to get the priority and visibility it requires. There was a detailed conversation there, more particularly about an item which we will return to under Saj's paper later on, around things like the prominence of people with learning difficulties in our waiting list management strategy, and the broader issue that COVID has shone a light on around BAME and broader health and equalities issues, and a commitment going forward to substantively work through exactly that point about inclusion in any of the digital transformation work. It links also, Max, to a follow-up from my presentation to the Council of Governors, and a number of the governors have reached out to me afterwards and said they were particularly interested on that element of my presentation. So I'm hoping after the summer break to cement those things together. I would say it's closed insofar as it's in the right place, but I'd expect the board to anticipate, you know, a detailed and documented output from that work, you know, probably in the autumn stroke later in the year, if that's okay with the board.
Thanks very much, Paul. I'll just pause and see if there's any further comments or questions. So, Paul, and may I just check with you, and sorry if this is a bit of a late question, but in this context, by inclusive digital transformation, did we mean record keeping that's capable of identifying specific characteristics?
It's a bigger topic, really, about, as we move to strategic objectives around things like the virtual Royal Infirmary, how do we ensure that we're not inadvertently disadvantaging groups of our population, either at one level in terms of affordability of data and access to the internet, right through to the skills in that population and their confidence around using digital and data. So it's actually the reason why it's included as the term of art is actually there's an awful lot to it, and each element of that may require a different conversation. So we, for example, are engaged in conversations with the council about the digital infrastructure in our wider, you know, for our wider community, right through to relationships across West Yorkshire and Harrogate, which are about the skills in the staff group and the skills in the population. So it's a fairly sophisticated topic, Max, and if it's appropriate, I'll bring back a presentation with at least details those layers to colleagues and the work that's going on in each respective element and dimension of it. So yeah, it's much more than just, are we picking out the possibility and identifying the characteristics of our population on our PTL, for example.
Thank you. I'm very encouraged by that, Paul. And it's great actually to see that there's going to link there with the EDC and report back, and a good relationship with that work. So thank you very much indeed. And in the absence of any hands raised or further comments, may I suggest that action can satisfactorily be closed, or Paul's assured us that there's work underway in relation to that? Yeah, I think we can. Good. Thank you very much. Thanks for that, Paul. Yeah. And then the next two are shown as October and January 2022 updates. Patient Recruitment Centre, discussion around a possible visit to the Patient Recruitment Centre to be held at a later board development session, and mental health strategy updates provided in around 9 months. May I just check whether either Laura or Karen have anything further to say about that? If not, I'll assume that there's work underway to make sure that they're achieved within the timescale suggested. Yeah, looks that way, doesn't it? So we'll retain those two. And then I think the final action then is the strategic partnership agreement. And this was discussion to be held with colleagues across the system regarding whether a best practice template for the strategic partnership agreement exists for use during the next revision or the third revision of the document. John, is there anything else? I realise it's April 22, but is there anything you'd want to advise colleagues on?
It's not something that has a fixed endpoint. We are working on the next iteration of the strategic partnering agreement, but until the dust has settled on the current legislation that's going through Parliament, it would be a bit premature to say we've nailed it all. And there isn't, so far as we're aware, a template that we can simply lift and shift, because nobody's doing exactly what we're doing in the context we're doing. But I have raised it with Vicky Wallace and colleagues and said, let's just not reinvent the wheel. If there is something out there we can use, let's do it. And we're also talking to Robert McGough, who's the lawyer helping us with this. So we've taken the point forward. To be honest, Max, I think you could probably close it off here, because I'll say the same thing every time.
Yeah. Okay. So assuming board colleagues are assured that John's got it, that our discussion is taking place. And John, may I just check, because I obviously perhaps wasn't part of that discussion, is the idea of a best practice template, the idea that partners to the agreement might be operating in the same way?
It's less about partners to the agreement. I think it was Julie just saying, let's not reinvent the wheel. If there's something out there we could use, let's use it. And we've gone forward in that spirit. But at the moment, no one else is quite in our shoes. Everybody's finding their way. But we're sharing what we're doing, and other people are sharing what they're doing.
Okay, great stuff. So again, I'm just assuming in absence of further comment, and there's a couple of thumbs up, etc. So that's great stuff, John. Thank you very much. I'm going to propose that action's closed on the basis of there is certainly ongoing work in relation to that. Thanks, everybody, and thank you, John, for picking up on those last couple as well. Thanks for that. Okay, I'll move to item 6, which is the report from the chairman. So I'll just pause for a second, guys, and hopefully you've all had the chance to have a quick look through that. It's necessarily on this occasion kind of focused on governor activity. There are 7 items on the chairman's report, and I thought there were maybe just 3 things I would emphasise to you. The first is that I'm very pleased to confirm that we've appointed 4 new governors, and I'm told that the 4th, that the necessary checks have come through, and so therefore her name has stayed in my report. But honestly, we have board colleagues, we have some terrific new governors that will provide us some really genuine inquisitive inquiry, and I think will be extremely supportive, but appropriately testing as well and take us forward well. So it's great stuff. Adrian, so this is item 2 of my report. Adrian Cresswell is a highly experienced ex-head teacher. He's Bradford through and through. There's a lovely comment in the profile regarding, I think, his mum, who spent 40 years as a nurse with us, and he'll be a terrific addition to governors. Caroline Chapman joins us as the new public governor at Shipley. Caroline possibly was going to join us today, actually, but I don't think she's on the call. Yeah. So, and Caroline is the communications lead, actually, communications and marketing lead at In Communities. And I apologise if people have already read the things there, but I'm pointing out to you that she comes from a public sector organisation, basically, but with a senior role in that as well. And I think, again, she'll be a terrific addition. And then Ibra Hussain, who is, in fact, a lawyer, and he's also now a Bradford councillor, and takes up the the Bradford West post. So really terrific additions there. And then I'm delighted to welcome the new partner governor, Professor Anne Forster. who, although she'll be representing the University of Leeds, has spent a long time, I think 30 odd years, working out of BTHFT within our research programme. And Anne is head of ageing and stroke research with us here at BTHFT. So, you know, really good additions. It's pleasing to see the quality of people that are putting themselves forward to be governors. And may I, on the second thing I thought I'd mention is just let's note at Board of Directors, as we did at Council of Governors, that we thank sincerely our staff governor, Pauline Garnett, for everything Pauline has done for us. And indeed beyond BTHFT. So Pauline took up, you know, a few kind of national positions. She worked with the National Governor group and was on the National Committee, and she's been terrific. And she's done well. She's got herself a promotion where she'll be going to Barnsley Hospital to work there, I think in equality actually, in that sort of domain. So she's done terrifically well, and I'm sure directors will join me in congratulating her, but also thanking her for the commitment that she's given towards her role as a staff governor. And then the third and final thing I wanted to mention was, and I think I've done this 3 or 4 times now, but I'm going to repeat myself and thank particularly, as amongst others, Sarge and Paul for 2 terrific executive briefings to governors. And I just wanted to remind you, it's a word I had with Mel after the session. I just brought to Mel's attention how well they'd gone down, and but also how well the guys, Sergeant Paul, had done on the day in terms of the quality of the presentation and the detail and the interest. And genuinely, exec directors, they're really well received. They are seen as a courtesy to governors, and there's no question in my mind that at the end of them, not only are they better informed, but they're actually more supportive and understanding of the way we're trying to go forward and understand some of the challenges. So I did just want to raise or put down at Board of Directors my sincere thanks to all exec directors who give up the time for those briefings, and particularly to Sergeant Paul, who did the most recent of those. So unless there are any questions of my report, I'll assume that you're content to note that, and we'll turn to Mel and offer Mel the opportunity to bring to our attention verbally whatever she would wish to do. And that looks to be the case, Mel, so I'll hand the microphone to you. Thanks.
Thank you very much, Chair. And okay, so it's incredibly busy right now. You've got a little flavour of that already from our colleagues in the CBU, and I will touch on that. But there are a number of reasons for that. And I'll start, as I normally do, in terms of people, partners and place. And our people is the proxy really for all our staff and all our patients. So what are our patients experiencing right now? We find ourselves in a position which is quite a significant increase in our COVID inpatients. So a month ago, we had about 8. That was the lowest number of COVID inpatients that we've got. And at the moment, we've got probably around 44, between 44 and 47 probably today. It's a different sort of cohort, it's feeling like. There's a significant number of younger people, and they confer slightly different demands, particularly in respect of critical care and very high intervention support. So we're finding in this cohort of patients, almost 50% of them are requiring what we describe as very high level 2 or level 3 care in critical care or on our respiratory ward. So 6 patients currently in critical care, which is a very high proportion of that 44, and 16 on NIV. So we know that our COVID numbers are increasing, and we don't feel like we felt yet the kind of 2-week lag that's associated with things like the Euros, the 2-week lag associated with so-called Freedom Day, and of course yesterday we had, or the couple of days preceding that, Eid. So it looks like we will be on this upwards trajectory, and what that means is that we have to plan not just to operate in one COVID red area, but potentially several more before we peak at the whatever that number of this 4th wave may be, and then it begins to dissipate. And whilst all that's going on, of course, we are constantly promoting, encouraging, endorsing and participating in the campaigns to both publicise and make the public aware of, but deliver the COVID vaccine to the age groups who have not yet received it. At the same time, we are continuing to experience huge numbers of emergency attenders. And just by comparison, if I were to say around the period of the kind of pandemic, between the two waves of the pandemic last year, we would, because of course people were in lockdown, and you've heard from Helen, that had a phenomenal impact on decreasing demand for paediatrics. Well, so too did it decrease demand for adult urgent care. We would see maybe 220, 250 attendances per day at A&E. Our normal is, has been pre-pandemic about 420, 430. We have seen a record number of attendances, and we peaked at our record-breaking high last Monday of about 519.20. So these are massive, massive levels, of which some of those are children because of that RSV issue. And so that plus the COVID is putting an enormous strain on our emergency responses as an organisation, and also our critical care responses. Add into the mix the requirement for us to achieve certain targets on elective recovery, which we're doing reasonably well in, and certainly as a place in aggregate, Bradford District and Craven, and indeed across West Yorkshire, collectively we were delivering more than the target expected of us for elective services. Some of those day care, some of them overnight stays, outpatients, and follow-up and diagnostics, and we were doing reasonably well. But once we get into a scenario where we have to open more and more COVID beds, then we will require the staff with the skills to look after them, who predominantly reside in the theatre specialty, so anaesthetics, ODP, theatre nurses who can look after people on mechanical ventilation or NIV. We will have to redeploy some of those to expand our critical care infrastructure. And that will, by necessity, mean that we cannot do the elective operating work that we plan to. Now, of course, as we clinically prioritise these patients, we will always endeavour to do our very, very urgent cancer cases and keep that going. But the more run-of-the-mill, more routine cases, and these are still very high clinical priority cases because of the size of the backlog, will inevitably slow. So I think we should be aware of that and expect and understand why that might happen. Add into the mix the fact that we have a very tired workforce, we have a heat wave, we have people whom, if this had not been happening, we would be encouraging to take annual leave because they actually have accrued so much from previous years and potentially carried some of that over into this financial year. And we would be encouraging them to take leave because of that, compounded by lots of our people, particularly parents, having school children coming home with either COVID or being in contact with COVID. The impact of the track and trace system and the NHS app that pings, so this pingdemic, as it's being referred to, which is telling people that they have been in proximity of someone who has subsequently tested positive for COVID and therefore should self-isolate, is really having a detrimental impact on our staffing levels. So we are struggling to cover the gaps that at this time of year under normal circumstances may be difficult to do because nobody really wants to volunteer to work extras when it's the height of summer and there are nicer things to be doing. But it is just making that a really, really challenging scenario. And part of the reason why our staff in the command centre and the matrons are so exercised at the moment is not dealing with necessarily care demands. It's trying to move staff from one location to another to make sure that we have, if not optimal levels, safe levels of staffing, because that's all we can hope to achieve under these scenarios. So operationally, that's a real issue. Some of the things that have happened then in the last couple of months, we received a letter from the BMA, which was imploring us as an organisation to revisit the issue of the level of PPE protection that we are offering to our staff who are operating in red areas. Now, this has been an ongoing conversation and dialogue really for the last 4 or 5 months, I would suggest, where there has been an increasing amount of evidence being put forward that a higher level of protection afforded by what we call an FFP3 mask can protect staff who are working not just in aerosol generating procedure areas that we would determine, for example, being critical care or Ward 31, where we have NIV patients, but any general red area where a patient may have or has confirmed COVID. And in recognition of the evidence, I asked our clinical reference group, who are made up of our clinicians, to advise the executive team and myself as to whether or not we should move to a policy whereby we give all staff in red areas FFP3 type masks, as opposed to the general surgical mask that we are all wearing when we are out and about in the hospital. Their advice was, based on the evidence, there is certainly evidence to suggest that staff are afforded higher levels of protection by wearing these masks, and we made the decision to implement that as a policy. I shared that with my colleagues at Wyatt, and I believe that they are, if they haven't already, following suit. They are certainly considering that. But I think it's important to recognise that it is kind of out with the national recommendations at the moment. We have the latitude to do that if we believe it to be warranted, and that has been the case. But it is also the case that a lot of our staff have been asking for this for some considerable time, and I think it's the right thing to do in response to that, given that there's now a strong evidence base to support it. Feels a little bit ironic, but it is the case that in this heat wave, we've spent the last 2 or 3 weeks distributing the hoodies and the fleeces that were our thank you gifts. As I say, not something to be worn today, although Saj has, and I've seen him modelling his own this very morning. But again, that was out with our control. It was an issue of supply because of lockdown, and the company couldn't supply them, but they are been very well received, and my take on this is it's just really good planning for winter. At the same time, then, to compensate for the fact that they're getting their gifts late, and who wants to wear a hoodie or a fleece in 30 degrees, we did organise, you may have seen on social media, ice cream vans to distribute lollies and ice creams to staff earlier on this week. Again, that was very, very well received. You know, I went on social media, and you will appreciate, in a building built and designed in the 1930s, air conditioning wasn't something that was terribly fashionable then, and we suffer the consequences of that. If you think of where the sun sort of goes over the course of the afternoon, the majority of our wards are in the full sun in the latter part of the day, and it makes for really, really challenging working conditions, particularly when you are in PPE. So we're trying everything we can to try and alleviate that, encouraging staff to take breaks, encouraging them to have open windows, obtaining air conditioning units where that's possible to do, making sure that they have an adequate supply of bottled water. I mentioned the ice creams. You know, it doesn't take away from the fact it's uncomfortable, but we do know that this only tends to happen 6 or 7 days of the year anyway. So we just have to kind of hang on in there and provide as much support as we can. Moving on to partners, in line with ourselves, in recognition of the pressures, Wyatt has reinstituted its Gold Command scenario, which is 3 weekly meetings of, not 3 weekly, but 3 3 times a week meetings with the chief operating officers, chaired by a chief exec, in which we will have conversations about the need for mutual aid and understanding the various pressures across West Yorkshire. And I know that paediatric critical care in particular is presenting a problem right now, and we will all be expected to surge and probably support Leeds as the tertiary paediatric intensive care specialists by possibly taking some work from Leeds to create the space for them to take the sickest patients, the sickest children. The ICS continues to work through now what have come into legislation, the white paper implications. Rob Webster has the ICS leaders taken on that role on an interim basis full time until the formal appointment process can be undertaken, which would see not just our operational ICS lead, but also a chair appointed, and we're expecting some announcements about when that process will begin very soon. Underneath that sits various strands of work around the whole design and transitions piece as CCGs begin the process of creating a transition pathway from a CCG to its successor, which will be the ICP arrangements in the 5 places in West Yorkshire and Harrogate, and the role of the ICS as it takes on its more formal responsibilities around commissioning and managing services. For our part, we are kind of playing into that. I sit on the ICP development work stream and have been able to input into how those places will develop. And moving on to place is a helpful segue. We continue to mature and work very effectively. Our Act as One brand is very kind of prominent and has a high profile and is becoming a more trusted brand throughout the region as the way of working collaboratively and in partnership in place and being effective in so doing. Our Act as One festival, which was in full swing the last time this board met, was incredibly successful. I don't know whether people were able to access some of those sessions, but in short, there were 30 sessions over the course of the month, 50 external speakers and internal speakers, and over 1,000 participants. So we managed to attract some really high-profile people to that, including Prerna Rizar, the national people person, and Chris Hobson, the chief exec of NHS Providers. We also hosted a couple of really prominent visits from national directors this month. That was Amanda Pritchard, the Chief Operating Officer for NHSI, and Matthew Gould, both of whom came and had a good look around our site, spoke to our staff, spoke to the leaders, both here and across Act as One, and I hope left with a very positive impression of how we are doing as an organisation and as a place. Within the place, Chairman's already alluded to the strategic partnership agreement, but there is something that we have to do as a place, and that is to find a way of determining who, when Helen Hurst steps down and retires in April 2022, will be our place-based lead. And I'm fully engaged in the conversations around that, and we have yet to confirm who that individual will be. And when I have any more to report on that, I certainly will do. So lots happening, Chair. Happy to take any questions.
That was great. Thank you very much. Lots of detail and almost a partner's place system there. So that was great. Thank you. I'll open up for any questions, any further detail required. And in the absence of that, Mel, I just had one question, please, and then I'll come to Paul. So that's just a quick one. It may be that this is far too early, but we've heard the news today regarding the offer of 3% pay rise. And I was just interested, exec colleagues, whether there'd been any official local reaction in relation to that yet, or whether perhaps that's all a bit early. But Is there anything being said locally, do we think, Mel?
We haven't actually received any official notification of it. We've read about it in the media, so not yet.
Yeah, okay, thank you very much. I think it's a story that's going to run, isn't it, with a look at the early media cuts on that. But thank you for that. Okay, thanks. Paul, would you like to come in?
Sorry, Max, I don't want to be unduly flippant because I think Mel's, the first half of that was very much identifying the operational pressures that the organisation's under. But interestingly, in an ICS level conversation I was involved in yesterday, we even appear to be ahead of the game on 3-letter acronyms, because I think an ICP is now what they're beginning to talk about in the context of the legislative arrangements around what was up until last week an ICS. So not only is Bradford ahead in many other ways, we're even winning the acronym race in terms of properly reflecting partnership working.
Thank you, Paul. Yes, yeah, good point. Yeah, thank you. And Julie, would you like to come in?
Just reflecting on, Mel's conversation with us, and she had a similar conversation with governors last week on Thursday. What do we do with staff? Because this, it's really sobering to listen to, because we were hoping the vaccination was kind of a move away to a more normal world again. But what we're seeing is that's not going to happen, is it? Through this winter, it's going to be really tough. What are we doing with our teams to actually keep some motivation going? Because it must be really hard from now 18 months in and knowing this is not going away.
Good point, Julie. Mel, would you like to address that?
Well, I'll kind of kick off, but other colleagues can come in. So I think,
excellent.
So you've heard from the CBU, the Children's CBU, and I think you asked the question, what more, Selina asked the question, what more could they want, expect, need? I think what we can do as an exec team is make ourselves visible, make ourselves approachable, make ourselves be a listening executive and a responsive executive to try and do the best we can, and try and always think about what is it like to be a member of staff here. So it's really hot, let's give them some ice creams. It's a little thing, and it really is a little thing in the grand scheme of it, but it says a lot about the intent and the thoughtfulness of this team being able to respond to some of that stuff. So I think that's the first thing that we can do as an exec team. We can try and make sure that the conditions that they're working in are as favourable as they can be. That's not just the environmental things, like have they got the right tools to do the job. Some of the responses around the heat, for example, were saying, okay, largely speaking, some of our usual expectations around uniform have gone out the window. If you want to wear a t-shirt because it's more comfortable and we haven't actually got scrubs, then you can do that. And we've given t-shirts out and other things. So there's that little bit. There's the pay and conditions bit. So we can try and keep everybody in line with what other colleagues are doing. And there's a big pressure at the moment in terms of trying to understand the differential pay rates that may have been offered in more recent times in other organisations because of the market and the demand and the pressures. We can make sure that they can raise issues in as responsive a way as possible, so they can use incident reporting, they can use freedom to speak up. We've got all those mechanisms in place. We can use our resources as wisely as possible to try and augment some of the pressures. So just this Monday, we agreed a considerable investment to recruit additional healthcare assistants. So, we can be seen to be responding to the need for more staff and more flexibility in our staff. And we can do the whole kind of psychological support that we've continued to offer throughout COVID. We've just appointed our new staff psychologist. Yesterday, I was with briefly the OD team who had an away day, and everything they were talking about is how we can make the experience of being a member of staff in this organisation as positive as possible. So there are a few things, but you know, I see other colleagues' hands are up.
Can I just add, Mel, as well? I think there's also something for us as a board about how we keep the exec team resilient. So I can see lots of work, but we also need to keep you as a team resilient, and we need to think of as a board how we can support you in that, because it must be really tough. And I can see all the things we're doing for our teams. I can see them, I hear them from the CBUs, but I think there's something about keeping you as an exec team resilient as well. Because it must sometimes feel like.
Yes. Yeah. Thank you, Julie. Yeah. Okay. Well, let's hear from Karen, Pat, and Ray, and then I'll come back to Selena and obviously check with yourself, Julie, if there's anything further. So, Karen, would you like to come in?
Thanks. Great point, Julie, on resilience of the team. What I would say is that as a team, we're very well formed. We know each other. We know each other's strengths and weaknesses. We know when each other needs some help and support, and we've got a real close-knit community as an exec team now, where we are very supportive and in tune with each other, which is a great help, and it feels very different, as Selena was saying, than it did 18 months ago or 2 years ago. So that's really positive. So I was just going to say, really, some context. It feels like the 27th of December every day. And for those that, you know, 26th, 27th of December are the worst days ever, because you've no beds, you know, etc., etc. And things like bronchiolitis in paediatrics, you used to get 2 waves, one around October, November time, and then one after Christmas. And actually, we're seeing numbers of respiratory illnesses in children and young babies now in the month of July that we'd normally see in winter. And as well as that, we're seeing increasing numbers of non-elective green patients, so non-COVID, and then we're seeing the COVID come in. So I would say that staff morale is pretty low at the moment. We've then got people we've got the ping-demic, that's the new term, I think. So people being pinged on this app. So for me and for my team, it's about being visible, and it's about listening, and it's about caring. I'll give you a very quick example. So there was a staff nurse the other day in tears to one of the senior nurses, because for 3 days on the trot, she'd not been able to get off work on time. And she didn't mind that, but what was terrible was that she was late picking a child up from nursery, and because of that, nursery had fined her every day that she was late picking the child up. And, you know, this was reflected back to me, and I said, well, we should be paying for that fine. We should be working through that, because that's us that's caused that. And, you know, so it's little things like that. And sometimes when we just listen and we're visible, it makes a huge difference. So I've moved my team back to stopping non-essential, only doing urgent essential stuff, and going back to having a 7-day-a-week presence and working till later in the evenings, just to provide that support and cover. Because sometimes all it takes is somebody to go, are you all right? Have you had a cup of tea? And they go, oh yeah, we're fine. Whereas, you know, it's just that visibility really and leadership.
Thank you, Karen. Very good points. And Pat, would you like to come in?
Yeah, I think Mel and Karen have covered most of the points that I would have raised, but just a couple of things. Like, it's sort of making sure that staff are aware of the support available, whether that is internal or external, and making it easy for them to access services if they need that. I think it's also sort of thinking through the decisions we make that may impact on staff. So it would have been very easy for us this week to say all annual leave is cancelled, but that would really have been sort of the wrong decision to make, sort of from a health and well-being, perspective. So it is sort of really, you know, thinking through those hard decisions. And then it's sort of not forgetting the support departments. So because of the pingdemic, as we're calling it, sort of the occupational health team, the infection control team have been really, really stretched and pressured this week. And it is, and we sometimes forget, you know, about those departments. And it is being able to put in sort of additional admin support, some additional resources to help, you know, teams like that get through and recognise the contribution that they make. So those are just a couple of additional things from me.
Yeah, no, really helpful. Thank you. But this is an important discussion, actually. So thank you. Thanks, everybody. And Ray, can I turn to you, please? And I'll then just check if Selina wanted to make a comment. So Ray.
Yeah, thanks, Max. Just to add a little bit to what's already been said, as well as all the pressures that we've talked about in terms of what's happening clinically to our services in Bradford, we're also pressured in terms of staff numbers at the moment. It's been a difficult 16 months, of course, and we are finding that keeping hold of staff is sometimes difficult, and this isn't a Bradford problem. This is across the acute sector. People are going to quieter sectors, so private sector, for example. People are leaving to go to agency. Agency rates and demand have never been higher, and we've seen this. I've seen this over my sort of 20-30 year career. The time of the agency comes and goes, and it's coming again. So we are seeing staff moving into perhaps easier options, and it's understandable. The groups actually that seem to have coped best with the last 16 months are perhaps the groups that you might not expect. So intensive care, for example, care of the elderly, respiratory, have borne a significant part of the impact of COVID. And actually those teams are the ones perhaps that have come out of it better and stronger than they have before. And I think the key word there is teams, because those teams stayed together, they supported each other, and they probably never felt more in touch with the colleagues and more supported by the colleagues. So I think what we need to try and do is support the teams as much as possible. Some moving around of people is unavoidable when you are having to shift the footprint of our clinical wards almost on a daily basis, as we've seen before. So some of that is unavoidable, but to try and keep people together as much as we can, to support each other as much as we can, and do what we can in terms of continuing to develop staff, train staff, support staff, so that they actually feel valued. Money's one thing, but you know, if you look at most surveys, money isn't the top of the list of most people in terms of job satisfaction and what keeps them going to work. It's how they feel about going to work. And it's just trying to make that feeling as good as we can given difficult circumstances. So for me, it's about keeping teams together as much as we can, supporting them as much as we can.
Thank you, Ray. That's really helpful insight. This is a terrific discussion, by the way. Selina, I'll come to you now and then go to Paul. So, Selina, I know you did have a hand raised. It was a point you wanted to raise, please.
Yeah, Julie asked the question, but I've got another question. So my question is for Pat, and it's regarding leave. Are we confident that everyone who needs to take their leave has taken their leave, so that we're building that resilience for the winter? Because my worry is if that they haven't taken any leave in the last 18 months and then we're going into winter, will they be able to give?
What do you think, Pat?
So compared to last year, we've got a much higher level of confidence that people are taking their annual leave. We have obviously, I think people obviously have been tired. They've wanted a break from work this year, and whilst they mightn't necessarily have been able to go abroad, they have sort of tended to organise holidays in this, you know, in this country, etc. So I can't give you sort of, you know, a categorical assurance at the individual team level, but certainly when we look across our e-roster in terms of numbers of people taking annual leave, percentage of leave at CBU level, I am assured that people are taking leave.
Thank you, Pat. Selina, was there anything further you wanted to follow up on that?
I think it's just for us to be, you know, assured as much as possible at the level that we can get to, just so that, you know, there might be some people who consistently and who are very good at taking their leave, and there might be others who just don't get round to it because of whatever reason, or who can't just say no to their boss. So I think we just need to be sure that that's equitable and that everybody is taking their leave.
Thank you, Selena. Pat, do you accept that?
Yes, I do. And like Karen's just put a comment in the chat, which I'd sort of also accept, that people do take annual leave and either sort of pick up bank shifts for us, or actually are more likely to pick up agency shifts elsewhere, which we're actually less cited on. So there is also a personal responsibility on individuals as well to ensure that they take the necessary rest and look after their health and well-being.
Yeah, your point's very well made, Selena. Thank you. And Pat, thank you for your response. Karen, would you like to come in? And then I'll then go to Paul. So if that's okay, Paul. Karen, I'm guessing it's a point raised in this discussion that's of interest to you. Yeah.
Yeah, thank you. I was just going to ask, do we ask people what would make the difference for them? Because obviously they're the ones with the pain, and they'll probably have some answers as well.
Great point. Great point. Yeah. So Mel,
Yeah.
Karen, did you want to come in on that?
Yeah. So when we had a really big listening event, and we received the outputs from that exec management team predominantly from the critical care teams and the staff on 31, and they came up with almost a wish list of all sorts of different things that would make life better. So I'll give you an example. A radio. I wanted a radio, so we bought them a radio. We put these things called wobble rooms in, which was a sort of a redesignation of a space that we were able to equip with certain fans, fridges, radios and things like that, so that people could go and take a break. But some of the things were how wards are configured, and some of the things required some capital investment, and we did those as well. I know Karen's got a hand up, but yeah, we do listen, and we do try and respond positively to those. And sometimes, we have the conversation, and staff will say, well, I don't know, but they kind of, it's just a moment in time that they're feeling overwhelmed, and they'll have the conversation, and then you kind of say, and what is it? If I could give you one thing, what would make the difference? And they kind of say, well, nothing really. Sometimes they do that, but when they don't do that and they come up with practical things, we try and, within reason, support them.
Thanks, Mel, and thank you. Karen, would you like to come in on that point?
Yeah, just following up on, when you ask people and they go, oh, I don't really know, that's quite common. But sometimes it's just the simple things and the fact that we're visible and shown to care. So, for example, the fact that on Friday, we didn't wait for everybody to go on Saturday and Sunday. Oh, it's too hot, can we have permission to take our tights off? But we sent something round that said, you can relax the uniform. And we went one step further that said, and actually, the tunics are really hot, so wear a t-shirt. And if you've not got a BTHF t-shirt, wear a plain t-shirt of your own. Those little things go down well. Not everybody does it, but they go down well. The other thing that staff want when you ask them is to feel safe. And this is particularly important for registrants. And they feel that if something was to go wrong when staffing levels are at bare minimum, that they would be blamed and then struck off the register. So there's a lot of reassurance that we do around that. So we've brought the NMC in to speak to staff about that and explain how things work, but also to say, we know as an exec team what the struggles are. And actually, if you're doing your best, you're not being reckless, you're escalating your concerns, that's good and that's positive. But you've got the air cover that means that we recognise that not everything will be done to the standards that we always aspire to it be done, but we will always keep patients safe, and that is our mantra when we escalate like this. and staff just need to know that we've got their back and they won't be blamed. And I think they know that now, and that is a bit of a step change that we've had.
Thanks, Karen. That's really helpful insight. And Karen, did you want to come back on anything you heard there in relation to your question?
No, I've just put a comment in the chat. I think the fact you ask is really probably what makes the difference as well.
Yes, good point. Yeah, thank you very much. Great discussion, actually, an important issue, so thank you. Paul, my apologies for keeping you waiting. I was trying to make sure that people who maybe had something relevant to a point being made had the chance to speak, so the floor is yours, Paul.
No problem, Max. I'm eschewing the opportunity to reflect on how comfortable I was without my tights on Friday, but just to pick up a couple of other bits. I mean, I think we have some scarce resources in some areas, and I think to challenge people about being on leave but permanently available. You know, I have a number of people who answer questions about taking leave by saying, but my mobile phone's always a bit on and or always at my side if you need me. So I think there are a couple of areas like that, you know, it's beholden on each of us as leaders to say to people, no, you're on leave, and leave means leave. I also think there is something about, as we move back to some, you know, model of working where people are coming back into our built environment, some of the elements of that built environment aren't great. And some of those haven't been great historically. And again, I think there's something that collectively we know we have to keep doing about that. In my sort of feet on the ground and sort of eyes to heaven moment, I do think equally, you know, we are outlining some really ambitious strategic opportunities for staff and for the city more broadly. You know, we have the Mark's work on the SOC about the new hospital, you know, the organisational design piece with CBUs, which is about earned autonomy and how they will work going forward. John and colleagues work around the virtual Royal Infirmary. And actually your point earlier on about Bradford hiding its light under a bushel when we do have some areas of excellence. So I do think we're really working the balance between acknowledging the operational realities of it's hell, you know, it's hot as hell today, so wear a t-shirt and here's an ice lolly, and saying to people there is a road ahead where we're big and ambitious and transformational. So I, you know, as someone who's been here 6 months, I think we're doing both incredibly effectively at the moment.
Yeah, good point. Thank you very much, Paul. Really interesting insight. Thanks. And Selena, would you like to come back in?
Yes, please. So, just one last question. With Freedom Day, lots of things have been lifted. I know in terms of safety, the hospitals and the NHS have continued as usual. Well, as per the new arrangements of COVID. I'm just wondering, do we anticipate bringing people from home working back into the organisation anytime this year, or is that a discussion for next year?
Thanks, Selena. Perhaps we should turn to Mel in the first place there about that point. Mel, is it something you've had the chance to reflect on yet?
We have reflected on it, and we've reflected on it because of in advance of the relaxation of social distancing and mask wearing, etc., through on the 19th. So in keeping with our ethos, which is in this hospital, everything will stay the same for now. We're following that line because a lot of the home working happened to create the space, the safe space, the safe physical space. So we can't really say, you know, we're sticking with the way that we were working and then invite everybody back in. I think that even if COVID had never happened, we should have been having these conversations about flexible working and working lifestyles and balance, etc. So that's a slightly different one that we will continue to have, but that's more related to work-life balance, recruitment opportunities, flexible workings, all those kinds of things, as opposed to because of COVID.
Thank you, Mel. Thanks. Selena, does that sound reasonable? Yeah. Yeah, great. So thank you. Thanks very much, Mel and Selena. Thanks. Julie, can I return to you just for the opportunity to have any last word on this issue? You raised the point. You made a very powerful point that I want to endorse. We care about our executive team and that they get the chance to have some rest and recovery, which is extremely important. So well said on that. But Julie, you raised the whole issue of suggestions and innovations to deal with tired staff And was there anything further you wanted to add, or are you content with what you've heard?
Content with what I've heard, but I think we need to thank the exec team for all their efforts on what they're doing. You know, seems to be doing entirely the right things, and I think we need to know as a board how tough this time is, because it's unprecedented. And I think, you know, we can't just talk about the good things. We just need to know this is really tough, and it's probably not going to get any better for the next month or so. Yeah.
Well said. Thanks very much, Julian. Hence why I wanted that discussion to flourish, actually. So I do realise that it's taking time up in the meeting, but that's an important issue, and thank you. And it was great, actually, to have so many executive colleagues with something to say on this issue. So I was delighted with the quality of the discussion. So thanks, everybody. And Mel, assuming you've had the chance to say everything you would have, you wanted to say, yeah. And thank you again for your very thorough updates. That's absolutely terrific. Thanks a lot. Okay, what I suggest we do is I've just had a word with Saj about item 9, which is the elective recovery update position. So obviously we've got a terrific slide pack from him there. I really hope people have had the chance to look through that. And I've asked if he would mind if we treat that as kind of a rather rapid briefing. So rather than going through a presentation, we'll perhaps ask Saj to hit any reminders, emphasise any key points he might wish to, but also let's get to the point of the paper, which is asking for some board approval on a couple of matters. So we'll try and deal with that fairly rapidly. With item 8, the reason I'm saying 8 and 9, by the way, is I think if we deal with 8 and 9 now, then we can take 5 minutes, can't we? Have a leg stretch and we'll come back and get on with the rest of the meeting. So that's how we're going to deal with item 9. But item 8 is the report from myself as chair of the Regulation and Assurance Committee, and that's simply there to invite us to note that, and obviously an opportunity to raise any questions from its content. It was a good meeting, great Regulation and Assurance Committee, 13th of July, but I will just check whether does anybody have anything they wish to raise regarding that meeting, or indeed the report in relation to it. And otherwise, are we content to be assured by that note, which I think is a really good description of what went on? Yeah, okay. I'm going to take that as we are assured, and we note the report from the chair there. Thank you, item 8. And so I'll turn to Saj for a last item before taking a 5-minute leg stretch. And Saj, if you would perhaps just bring to our attention anything you would have wanted to, without the full presentation, I'm sorry, on the elective recovery update position, and take us to the ask you have of the board, please. So, Saj, may I turn to you, please?
Thanks, Max. This is the sort of joint effort between myself and Paul in terms of coordinating this paper. As you've already highlighted, Chair, really detailed paper there, which is an 11-pager, which I don't intend to go through. The purpose of the paper really was to, number one, provide an update to the board on the impact that the pandemic has had on our elective programme, the progress that we've been making in terms of the recovery of our position, and that's demonstrated in the paper in terms of our cancer 52-week and 40-week plus patients, and the progress we've made around recovering P2 activity, so priority 2 level activity, and the proposed next steps that we wanted to highlight here. As you alluded to, the real area that I wanted to spend some time on was the recommendations that are contained within the paper, and to get board's approval and for board to note these recommendations. So the first one being the progress that we've continued to make in terms of improving our utilisation, the insourcing and outsourcing of work that we've been doing. But then in particular, given what the board has heard already from Mel's update, the pressure that we're under around this fourth COVID wave that we're experiencing, but also the unknown impacts of half 2 from a financial perspective that could potentially derail our elective recovery. So it was to note that was the first recommendation. The second one was to note the fact that our overall weights have improved, and that's as a result, as I say, of the increase in utilisation internally, the outsourcing and insourcing of activity. We'd hope to look for that to continue if we got the financial agreement for half two, and we're currently waiting on that. For board to note the fact that we continue to be broadly driven by the clinical priority, whereby we're trying to reduce the median wait time for patients who are deemed high priority, i.e. priority 2, to within 4 weeks. For the board to note the ongoing work to understand in greater detail the minority ethnic grouping impacts and the impact of multiple deprivation indices and the impact of learning difficulties and disabilities for patients and their outcomes. And then lastly, the recommendation that from the work we've done for us, for those patients with learning difficulties, and we've confirmed there's 20 patients there, for us to be able to bring forward their dates of operation and to prioritize their procedures. And then following board approval, obviously we'll take that to clinical reference group and look to enact that. So they were the key recommendations in the paper, Max, that I wanted to bring to board's attention and seek approval for.
Saj, thank you very much, and thanks for working with me in terms of a sort of rapid briefing on this. So can I begin by commending the quality of the report that was provided, please? I found that extremely useful. That sort of data, that sort of information, I think is terrific and very, very helpful to us understanding the challenges we're working on. So I'll look. The first thing I want to do is just open up and pause for a moment, just give people a chance to. Yes, I have read it, Max, and there was something I wanted to check, or so just see whether there's any questions arise from it, and then we'll deal with the 5 recommendations. I suggest the first 4 of which are probably things we're content to note, and then the 5th is this idea that actually we should be prioritising those patients with a learning disability for clinical work. So we'll take those as we get to them, but I'll open up for any questions or comments first, so there's a chance to do that. Stephanie, would you like to come in?
Yes, thank you. Mine was more of a query. Oh, I'm really sorry. I'm having carpet replaced upstairs if you start to hear loads of really loud banging. It was more of a query really of how often do we review what we classify as a P2 illness?
So I can come in. So basically what's happened is anybody who's been listed onto an elective operating list, so a planned procedure, the clinicians have gone through the entirety of the waiting list. On top of that, as a patient is being listed, they're being prioritized at the point of listing. And then what we've also done is we've issued out a letter to every single patient that's on the inpatient waiting list, which articulates what grouping they are currently in. And that goes from P2 all the way through to P5 and P6. And if the patient's condition is deteriorating or if they need to be seen earlier, for them to make contact as well with us. Because it's fair to say some of the P3, P4 patients will be waiting a long time. So we've done the initial analysis. We continue to do that for when we list the patients, but then we've subsequently written out to the patients as well to say, contact us. If the patient contacts us and says that they are worried, then of course the clinician will pick up their notes and go through in detail with that patient and see them either in outpatients again or reprioritize those cases. And we do see that that happens. So those letters are having the impact that we wanted.
Did that help, Stephanie?
Yeah, I think I was talking more about the framework of what classifies as a P2, so rather than the process.
Oh, sorry. Yeah, in that case, that's really easy because the Royal College of Surgeons have published the procedures. So there's procedures that are classified as priority 2 and conditions that are classified. So we use the national procedures and our clinicians go through and then can allocate what is a P2 and P3. So then you get consistency nationally across the types of procedures that are being operated on as P2. Yeah.
Is that helpful?
Thank you. Yeah.
No, thank you. Yeah. Thanks. Okay. And Saj, is that a publicly available thing? That framework?
I would expect it is, because it's been published by the Royal College of Surgeons, so I suspect it's available, although I haven't checked. I mean, we got it through a formal communication, but I haven't checked if it's available, but I don't think there's any reason why it wouldn't be available through their website.
Yeah, no, that's really helpful.
Just Google it, Max. It's available. It's a public document, so it is available.
There you go. That's really helpful to know and to actually mark that down for Steph's question. So, and thank you for raising it, Steph. Good question. Thank you, Saj. Thank you, Ray. Selena, would you like to come in?
Yeah, just when I was listening to you, Saj, you used the words learning disabilities and learning difficulties. When we're talking about these patients, which category are we using? Is it learning disabilities or learning difficulties? Because they'll have different needs depending on which category we're using.
Okay, I'll probably need to bring in Paul for that one, because he was commissioning the detail behind that. So unfortunately, it's a pass from me on that one.
And an element of colour might drain from my face, Selena, because it's a perfectly appropriate question. I've been trying to, this is the wrong way of saying this, but in terms of trying to avoid offence rather than being absolutely clear about, there is a formal process for capturing. Karen has a member of her team who has the skills base around managing patients with, and again, Karen can correct me about the appropriate nomenclature, but that individual then helps us understand across the entire level of presentation in the organisation whether we then flag in EPR the extent to which someone has differential needs on that basis and should be acknowledged accordingly. So without going Saj passed it to Paul and Paul's passing it to Karen quite that explicitly, I think Karen can help me out on this one.
Thanks, Paul. Karen, do you have a...
Thanks. We flag all patients, or we try to flag all patients with a learning disability on our EPR system, so we've got sight of them. So the definition of somebody with a learning disability is quite clear. It's somebody that's had that from birth. The categories you then go into afterwards is if people have had sort of brain injuries or other things happening that impacts on their ability to learn thereafter. And they're not technically classed as a learning disability, but obviously have needs around learning and understanding. The other thing to point out, and we talked about this on my respiratory steering group yesterday, is that the definition LD is quite high-reaching. So you can have somebody that is completely non-verbal and doesn't have very much cognition, right the way up to somebody that actually can have capacity or fluctuating capacity, is verbal, is active, and has a job. So we just need to be aware of that as well.
Thanks, Karen. Thanks, Paul. Selena, did you have a further point you wanted to make regarding that? Or are you content?
I think we just need to be consistent in our approach and interpretation, because it could lead to differential services being provided. And that's the last thing we would want to do. We provide services based on need, and we need to be able to categorize and interpret the definitions consistently. That's all I'm saying.
Yeah. Selena, thank you. I know lots of people, Selena, who use the words interchangeably. They mean the same thing by learning disability and learning difficulty. Do you have
I think it's wrong. I think people who have learning disabilities have learning disabilities, and it's from birth, which means that we need to acknowledge that people may acquire learning difficulties, and that requires a different response. So I think, we just need to be mindful of that, and our staff need to be mindful, and especially those who are coding and so on.
Well said. Well said. Thank you, Selena. That's really helpful input. Thank you. And Julie, would you like to come in? Oh, just on mute. That's it.
It's a point we've raised in Academy, but I just want to raise it here.
Yeah.
I'm interested in being able to forecast more where we might be at the end of the financial year. And Sad just talked us through in the Finance and Performance Academy how difficult this is to do at the minute. But I think if we're going to be truly moved to outstanding, we need to be able to say, where do we think we might be? given there's lots of variables, so we have got some for colonoscopy and a few of the other specialties now. We're starting to say where might we be at the end of the year, but you know, there's thousands of people in Bradford waiting for operations, and we can't say as a board when do we think we might get to some normality. Now, Saj has gone through with me all the difficulties, and I appreciate them all, but I do think we need to be able to forecast something at some stage in the year of where we might get to.
Thanks, Julie. Thank you. Yeah. And Saj, would you wish to respond to that?
Yeah, I think what, and as Julie said, we've had an in-depth discussion at finance and performance, but I suppose given the such short focus planning that we have in terms of the financial arrangements, the independent sector, and not knowing what COVID will do for us, or indeed a winter, it becomes really difficult to project and predict any level of accuracy where we will be. The one thing I can actually say is that with the work that we're doing internally, what we're trying to get to is a point of for priority 2 patients being within 4 weeks of listing, and that's the actual recommended area. So that's where we're really keen to get to, and I believe we will be able to get to that position. Any of the other, I mean, I can have a stab in the dark in terms of predicting where we might be, but like I say, it literally will be a stab in the dark with lots of caveats of all of these other risks that I've called out in terms of what the H2 projections financially might look like, what the independent sector might look like, and of course what COVID and winter might look like as well. So we can have a stab at that, but it might not actually be worth the paper it's written on.
Thank you, Saj. Yeah, thank you. Julie, thank you for bringing board attention to that issue as
Max,
well.
can I just add, great work on recovery. So I've got to say that to Saj and his team, great work on recovery, and the results are really promising. I should have said that first, but I just think it's important as a board we understand that at the minute it's not possible to forecast where we might be able to get to, and I think we need to understand that. Yeah. And that's not a criticism, great work on recovery.
Yeah. Saj, yeah.
Yeah, no, I was just about to say, I think it's positive when we get in this level of challenge and discussion in terms of, well, where's our aspiration and where do we want to go? That's exactly what it's about. And I think that's exactly what happens in the F&P Academy in terms of, okay, so that's great news. We've now got to a point where we've reduced our 40 weeks, and we're now back to a point where we've come over this big pressure that we had on 62 days. Where next? And it's always a forward look, and it's always that aspiration. I mean, I know my own aspiration is for us to be in the top quartile performance-wise in comparison to all of the other organisations. I've said April 2023 for that at the moment for that, but again, like I said, there's so many unknowns. But that level of challenge is welcomed. It certainly is useful to share with the rest of the team as well.
Thank you. Thanks, Saj. Thanks, Julie. And I don't think any colleague took it as anything critical. It's great that we've got somebody like you who's bringing to our attention one of the things we need to be aware of as an ongoing challenge. So thank you very much for that, Julie. Yeah, that's really helpful. So conscious that it would have been great, of course, to have spent an hour looking through the elective recovery update, but we did at least have the chance to review the data, and it's all there, of course, in our own time, should anybody wish to query anything further through Saj. But shall we get on with these recommendations then? So, Saj, I'm seeing them as kind of 4 things to note, and then the fifth being the one that might just need to open up to board and make sure that we're comfortable in this recommendation. And let's read that again. To accept the recommendation that patients living with a learning difficulty, so there may be something about the language there, with a confirmed P status are actively prioritised ahead of other patients with the same P status within the same P status cohort. To make strenuous efforts to determine the P status of those patients living with a learning difficulty on the PTL, whose P status is not yet decided, and to respond as above regarding prioritisation consequently. Following board approval, if given, the clinical reference group, business intelligence and operational colleagues will work up the process by which this will be enacted. So what we're saying, board, are we comfortable with the idea that those with a learning disability or difficulty ought, in fact, to be prioritised when they are of the same P status as others, in the spirit of trying to tackle health inequalities in our district? Now, I know exactly where I stand on this, but as a good chairman, I will open up and just offer anybody the opportunity to say anything. I do, well, yeah, I was going to say declare an interest. I don't particularly do it, but you know, I'm sure you know what I mean by that. Yeah, I have some personal knowledge. So, okay, I'm going to just check whether does anybody want to inquire anything further of that, and then I'm going to suggest to board, may I ask that we accept that recommendation and support it. And I think Saj and Paul, are we picking up on the point perhaps first raised by Julie that we might just want to be certain about the use of language there as to what we're saying?
Yeah, absolutely, Max.
Yeah, okay. And is it likely, may I ask Saj, is it likely that we're talking about patients living with a learning disability or a learning difficulty?
Yeah, and I think that probably isn't as specific as we'd like it to be on the PTL. So I think that will include both categories that we've managed to capture. I think there's further work for us to do in terms of making sure we're capturing everybody that should be on there. I don't think that this just represents the 20 patients that we've been able to identify. I think we've got further work to do with our clinical operational teams and making sure that we're accurately collecting that information.
Yeah.
But for the moment, there'll be a mixture of people with learning difficulty and learning disability.
Yes, yeah. And if people don't mind me saying, I think it's fair to say that there's excellent data that proves that these are people who generally don't have as good outcomes and certainly don't live as long a healthy life as others. And so it makes me proud, actually, if I may say so, to see us trying to do our bit to address that inequality. So that's certainly how I feel about it. But of course, I will respect any other views that there might be. But otherwise, may I suggest that we unanimously support we note the first four recommendations and we unanimously support the fifth. Would anybody wish to object to that? No, we're content to do that. That's great. Saj, I think it would be great if board were brought up to date with progress regarding that, please. I think we'd welcome that. And thank you to everybody who contributed to that discussion. That was great. Yeah. Okay, content to do that. Smashing. Thanks very much indeed. Now, this would be the break, but I am conscious that we've got a guest, of course, in Naz Bibi, who's just joined us. So what I'm going to do is I'm just going to quickly skip, please, to items 4C, section 4C, 12 and 13, and maybe just ask Mel if she would like to introduce Naz, and we could perhaps deal with the important issue of the disability equality video. Of course, Mel, unless you wish to do any update yourself first on Equality and Diversity Council. So I'll pass to you, Mel, and Naz, a warm welcome to you and thank you for joining us.
Thanks, Chair. I wasn't going to go through the paper. I would invite questions at the end of the video, perhaps if there are any questions on the paper. We've continued to meet as a council. I chaired the meeting last week, really well attended and some fantastic conversations. So I think, we continue to gather momentum. But one thing I really did think it would be great for the board to see, and apologies to those members of the board who have either seen this in the council or in the people group, is the video that Naz and colleagues, it was Naz's idea to do a video and to promote the work of the Enable Staff Network, and that's our network for staff who have disabilities, and to let people know it's there. And I will say no more about it because it speaks for itself, but invite maybe Naz to say a couple of words about who she is and her role in the organisation and as chair of the Enable group.
Yes, please, Mel. Thank you. So, Naz, can you hear us okay? And are you able to use the microphone to say hello and maybe even come up on screen? I'm not sure if you have a camera on, but hi, Naz.
Yes. Hi there, Max. Hi, everyone. I'm Naz. I'm one of the staff engagement officers at the Trust. And I'm also the chair of the Enabled Staff Network. So myself, I've got a couple of disabilities. So I'm autistic and I've also got ADHD and dyslexia. And I just really spent a lot of my time in life really sort of fighting against these disabilities and not wanting to accept them and sort of running away, really. And since I've joined Bradford, and the support and the encouragement from my team and just the working environment has really helped me accept and not only accept my disabilities, actually feel like celebrating them, that they're a positive, they're a strength, something unique and different about me. And that's why I really wanted to join, you know, our trust on this journey and help others in the organisation hopefully feel the same, or really just celebrate disability equality in our trust. And so am I okay to just play this video? I hope the technology does work.
Yeah, no, absolutely, Naz. And you have a board of directors that entirely support your aims. Please be aware of that. This is important. So, and I confess I've seen this and it's brilliant, but it'd be great to show it now and for colleagues to have the chance to remind themselves of it. So thank you, Naz. Yeah.
Oh, brilliant. Thank you, Max. Thank you. Can everyone see the video?
Yes, I can. Okay, yeah. A few thumbs up, Naz, yeah.
We don't seem to have any sound, I don't think, Naz.
Oh, sorry, Mel. Let me just have a quick look if the sound's on.
Naz, do you want me to share it? Because I've got it ready to go if you want me to have a try.
Oh, yes, please. That'd be brilliant.
I'll ask our tech guy, does it matter at all? Would it have any impact, Paul, if we all turn our cameras off or anything like that? We did have this problem in the council.
I don't think so, Mel. I mean, if we're on YouTube, that's the best way to do it.
There's some volume now, isn't it?
We've been really excited about developing a disability equality video, which we believe will really focus on raising the awareness and the profile of disability equality, certainly in terms of supporting those staff who have identified a disability or a long-term health condition. So as a trust, we are on a unique journey in raising the profile of disability equality across our organisation.
There are three particular areas that I've taken an interest in as a non-executive director. One is recruitment of consultants and doctors. The second one is patient access and patient experience. And the third one is health and safety in its broadest sense. Disability equality relates directly to all of these areas, and there are some fundamental things that I think we need to consider when getting inclusion and equality right. The Enable staff group are doing some great work, and I'd like to see more non-disabled allies supporting that work because it's important we see this as an agenda for everyone. It's important to listen to each other, debate, but to also remember getting the simple things right can really make things better for everyone.
When I was young, I was always told that I'm dumb, stupid, out of control, and that I'll never amount to anything, and that I could never be a professional. But look at my life now, it's quite the opposite. I have ADHD, autism, and dyslexia. And the message that I'd like to share with you all today is that if I can achieve this, so can you. I think what's really helped me is the fact that my manager and my team have always been really curious, so they'd ask me questions about my condition, what that's like for me, my experience, and not take something that's off the internet or in books or someone else's experience, because your disability, your conditions are very unique to you. Before I joined Bradford, I couldn't even ever imagine talking about my disabilities or even openly sharing them with other staff or friends or colleagues, and anything like that, because I was always so embarrassed. But now that's completely changed.
I was born with developmental hip dysplasia and spent a lot of my childhood and teens in hospital, and consequently when I grew up I wanted to work for the NHS to give something back. I've been very lucky working at the Trust because they're very supportive, and I've always worked with people who've been very helpful, helping me to do things that I'm not able to do and keeping me constantly supplied with coffee throughout the day, which is the main thing. I've been given an allocated parking space, and I've got hand controls instead of foot pedals, And the best thing that's happened recently is that I've been able to reduce my hours. So I only work 3 days a week now, which has meant I've been able to carry on working. So I've now done just over 40 years working for Bradford Hospitals.
I live with a condition, it's a chronic condition, a hidden disability called lymphangiomyomatosis. It only affects women and it mainly affects the lungs and the kidneys. My main problem with the condition is that it makes me really fatigued. At the beginning of COVID and the pandemic, I was given a laptop to enable me to work from home. The Trust also supported me with my shielding group idea by allowing me to hold a group every Monday. It initially came out of speaking to other people in the same boat as me, feeling isolated.
I originally came to the Trust as a midwife. I have just recently moved into a position in clinical education and I have relapsing remitting multiple sclerosis. For the most part, I look normal, fit and healthy, and manage for the most part to carry out my duties without any problems. The Trust has always worked, so in combination between occupational health and my managers, have always worked to make sure that I've got a good work-life balance, that my shifts are set so that I don't get easily fatigued and that I can still be an effective member of the team and that I can still contribute as much as my colleagues do. Shift work can be really hard, so they just make sure that they get spaced out and that I get, adequate rest periods between shifts. And then recently moving into a position within clinical education, obviously it's a lot different to shift work and clinical work, and I'm hoping that the slightly easier pace will have another, good impact on my health, but also that I can give back to the Trust by working within the education department.
Whoever is out there listening to this, please remember that your disabilities don't define you or your ability. In fact, it makes you special and gifted.
Be proud as disabled people, get your messages across, but remember, we're all human beings, so when you're asked a question, be polite with the answer.
Are you passionate about disability equality? If the answer is yes, then please come and join the Enabled Staff Network and help us on this journey. We want to make the experience of disabled staff and patients better, and we need your help. So come and connect and join in, and thank you for listening.
Fantastic, Naz. Fantastic. So to see colleagues proudly expressing the love of the support they're getting from within the teams and the adaptations that are being made, and of course the promotion of the unit is just absolutely terrific. Is there anything else that you'd like to? There's a lot of love for it, Naz. You might see some of the stuff in chat comments and for your role as well. So is there anything you'd like to bring to the Board of Directors' attention regarding the work in this area following that video? And then I'll turn to Mel and ask her view. So Naz?
Thank you, Max, and thank you everyone for your really kind comments and feedback. I think this video sort of is the first step, for us on this journey to help improve the experiences of staff and patients in regards to disability equality. And now we've got, more members of staff wanting to join our Enabled Staff Network, so we can see the numbers increasing there. I've also connected with the University of Bradford and asked if they could share this video as well. So before even placement students or anyone who's coming to do some work experience at our trust who has an LSP, so learning any sort of disability, we can really use it and promote that. We're hoping to promote it on our induction, intranet, Twitter, and really get the conversation going. And I've had some messages actually from CCG to ask if I could possibly support them to create their own personal unique video. So I do think it's hopefully the start of something good and special. But I just really would like to thank everyone involved in the video for their time and effort, and even sharing their personal journey, because it's something that it's not easy, you know. And I'd really like to thank Ruth, Mel, fantastic leadership, really supportive and encouraging, and just thank everyone here for their time and everything. Yeah, thank you.
Thank you very much, Naz. And the word inspirational is coming up a few times for yourself, actually, for your own role. And I'm so happy to hear that the CCG are approaching you for guidance on how they might promote that message even beyond our own hospital trust. So very well done from us. I'll turn back to you, Mel, and just give you the opportunity as CEO to say, is there anything you would wish to bring to directors' attention regarding this work and this video? But we're all genuinely inspired by it and better informed, Naz. So, Mel, is there any final words you'd like to say in relation to this?
I'm just so proud of Naz, you know, from the beginning of the conversation about how can we get more people involved in the Enable network and taking the responsibility to lead on this. It's just phenomenal. So if I said anything else, it'd detract. If I got a mic, I'd drop it, or I'd drop it on Naz's behalf and walk off. Naz, job done.
Because you can't beat that video, can you? So we're extremely well informed, Naz, and I can assure you of the board of directors' support for everything that's going on here. And I guess a lot of that will be taken through the Equality and Diversity Council, but also you're giving us the chance to advocate and promote the work that you're doing in your area, having watched that video together with you. So thank you very much indeed. I'll just open now, just check whether if anybody's got any questions or comments. There's been some lovely comments in the chat, which we always record, Naz. And clearly, I want, you know, I hope you will go away from board of directors knowing that we support this and we will advocate and promote it. And we've learned a lot from watching the video. So I don't think there's any further comments. So Naz, thank you so much for what you're doing. Very well done. You're an inspiration. And it's one of the things, Naz, that makes us proud of what we're doing here in Bradford's Trust. So well done, very well done. Did you have any final comments, Naz, or are you happy to leave it at that?
Just thank you all for your time, and thank you for the opportunity to share this video with you all. And I hope you all have a great rest of the day. Thank you.
Thank you, Naz. Thank you very much indeed. Bye-bye. Well done. Yeah. Well, that was great, Mel. What an inspirational woman, and doing terrific work. Yeah, great video. And I meant what I was saying. I'm sure directors would be very happy to promote and advocate for all that work wherever you required. And it was quite moving watching that, wasn't it? Mel, shall I take the opportunity now for people to be able to stretch their legs, and then we'll pick up on your E&D Council update, but I realise there's the quality items as well to deal with. So we may just be slightly moving towards the closed meeting times, won't we? But I promise to try and get things dealt with as we can. Great discussions, fantastic stuff. So look, I've got 12:02 on my computer. So shall we say 12:07? Shall we give ourselves 5 minutes? And is that enough time to boil a kettle or grab what we need to? And see you about 12:07. We'll restart. Thanks, everybody. Cheers.
Hi, Karen.
Hello.
Hi. Is board paused at the moment? I've been away
Just
from my
for,
desk.
just for a really quick break. So
I'm sorry, I can't hear you.
Oh, sorry. Everybody's due back at 12:07. So restarting any second. Can you not
Sorry,
hear
Karen,
me?
I missed that.
So it was paused just for a quick break, just till 12:07.
Okay, thank you. I shall see you all later.
Good to see you, Jackie.
And you, Selena. Last meeting again.
Yeah, it seems like the longest goodbye in history.
Yeah. It does get like that, doesn't it? Nearly there towards the end of August, though. I'll see you later.
Yeah.
Right, everyone. So I think I'm still influenced by that disability equality video. It was very powerful, wasn't it, to see, to see members of staff, colleagues, and of course even one of our own directors in the form of John, promoting and advocating the work that we're doing. So that's terrific stuff. That's great. And Naz presented that really, really well. So delighted. Okay, so we've obviously got plenty to do, and I'll try and make sure that time is properly given to those matters that require our attention. But I hope you'd agree with me that there's been some really good debate and discussion today, and we've really picked up a lot as a board of directors, sharing some of the progress and challenges that we've got. So I know we're going to come back to quality items, but I'll stick with Mel for the moment, and perhaps we'll deal with all the people issues. So equality and diversity council update, and then I think Karen might just want to bring our attention to anything related to strategic staffing review. So thanks again, Mel, for bringing the disability equality video to us, and anything you want to bring to our attention, please, from the E&D council update. Mel.
Thanks, Max. I would take the paper as read and invite any questions, and just ask for the boards to note the report and support the proposed actions and suggestions in sections 3.1, 3.2.
Yeah, perfect, Mel. So, and I don't know if I was entirely clear what the 3.1 suggestion was, Mel. My apologies if it's just me that's not getting that. 3.2 I've got clearly, which is developing the 3-year strategic equality and diversity strategy, isn't it?
Yeah, I think it's you're quite right, Max. I think it's just to note the video and to support the Enable Staff Network.
Yeah.
To promote that video more widely, and then to agree the timelines for the equality and diversity inclusion strategy.
Thanks, Mel. Yeah, that wasn't an intended test of mine, but when I read
it's not clear. I think it's well, there is no 3.1, so it's a bit of a typo. Well, sorry, no, the 3.1 is the summary of agenda items arising. So it's just to note the actions on those.
Yeah, that's how I took it, actually, Mel. That's absolutely fine. Yeah. Okay, thank you. So I'll just open up and ask whether there's any questions on the the work of the Equality and Diversity Council. I'd be very interested to know whether amongst non-executive colleagues you feel engaged sufficiently on that, or whether there's any issues that you would wish to raise for further attention, because it appears to me to be terrific work, and bringing together those different staff groups, etc., and giving them a voice and a platform seems to me very powerful. It's great to see Mel personally leading that as well. So I'll open up for any comments. Selena, would you like to come in?
Thanks, Max. I just want to echo what you've said. I think it's great that Mel chairs the Equality Council. I think it sends a really strong message about how seriously we're taking the agenda. And I think when it starts from the top, it inevitably demonstrates our commitment as an organisation. So I think, credit to Mel for doing that. And I think, it's developing, and the types of discussion that we're having are much more around action and not words, which I think is always another positive sign. So I think Mel chairing it drives that action focus, and it stops it going into a discussion forum, which is very easy to do because equality and diversity and inclusion are seen to be hard subjects to master. So I just want to have that recorded on record that, Mel taking that leadership role has been a really positive step, and I think we're seeing the benefits of that. Still a way to go, but I'm sure we will get there because that focus and drive is there now.
That's great, Selena. Thank you for the endorsement and your summary of the benefits that you see in that. So thank you very much indeed. And if there's no further comments, Mel, should I just maybe come back to you and ask, is there anything you would wish to say to the board of directors regarding the 3-year strategic equality and diversity strategy? Anything you'd want to pick out of that, or are you content that the report sufficiently addresses that?
No, I think just to be clear on the purpose of this, this is a very, very crowded space right now, and there are lots and lots of threads of action and lots of work going on which exist in place at a system level. If you reflect on the report that was done by Dame Donna Kinnear and things like the anti-racism campaigns and all those things, and then at the very sort of operational technical level of transactional stuff around employment opportunities, for example, we've got things like the res and the des and everything in between, really. So this is just a way of trying to create a coherent narrative that stitches all those things together for us as an organisation. And
that actually is a really useful insight into the thinking, Mel. Thank you. A coherent narrative. Yeah, with lots of things going on, but a coherent narrative, and one that's supported right from the top and brings people together. Yeah, engagement. Great stuff. No further comments? Are we all content to note and support indeed the Equality and Diversity Council update? Yeah, I think we are. Thank you, everybody. Okay, I'll move to item 14, which is the last one on this people section today. I do recognise, of course, that there are a number of reports appended for our attention. Hopefully people have had the chance to look through those. But Karen, what do we need to think about in terms of the strategic staffing review, please?
Thank you, Chair. So this is a document that in peacetime comes twice a year to board, and it's where I do my formal review of nurse staffing with all the matrons and the ward managers and the heads of nursing. Actually, over the last 18 months, we've done nothing but review nurse staffing on a monthly basis, and have tweaked that throughout. So, for example, we know that we have 2 respiratory wards now that are mirrored, 1 red and 1 green, so double the staffing requirement for that. What we've done, though, is as we've looked at the strategic staffing review this time, there are a number of changes that are potentially due to acuity. So, for example, we know that patients are coming in more deconditioned because of lockdown and isolation, and are requiring more rehab type support or support to get them up and mobile. Excuse me. So we have, and Mel alluded to it, agreed to invest £500,000 in recruiting more healthcare assistants. In addition to that, there is still work that we need to continue to unpick, and Saj and I are working extremely hard on this. So there is an element of all the wards have changed. So it's a bit like, you know, somebody's thrown it all in the air and it's landed and it's all in different places. So even though the bed base looks slightly less for inpatient, slightly more for day case, it's over wider areas, and it is very different in the acuity and how the wards are now. There's then a third tranche, which is about some of the business developments that we're seeing the capital works ongoing with at the moment. So around the POMU and changes to our surgical floor as well. So we do need to take some extra time just to clarify this. So we're working through these figures. We've got a series of meetings planned over the next 6 weeks where we can really nail this down and plan it over the next couple of years, what we need to do and why, and really firm up that recommendation. So we've not got the full paper here today. We have taken some urgent steps as an exec team to go out for additional healthcare assistance to get those in post for the winter. And at the September board meeting, I'll be presenting the full strategic staffing review, and I'm sure that Sarge will do the second part around the investments with me as well. So we're really joined up and really clear on what the ask is.
Thanks very much, Karen. Okay, so we'll hear the or see the full report in September, and I think Karen's sort of summarised for us helpfully where we are on matters such as staffing, and Sarge will be working alongside Karen to support that work. So I'll just check whether are there any queries or questions. Karen, is there any are there any implications of putting it back to September that the board might want to be aware of, or is it perfectly appropriate in terms of timescales?
I think so for a couple of reasons. So the most pressing one, and the thing that we can do something about, is recruitment of healthcare assistants. And we know now that it's good to have a big recruitment drive and to appoint for values and behaviours and to put in a package around them. And that's what we're planning to do. We know that when recruiting staff nurses, the best times to do that are when people come out of university. We've just appointed all of the staff nurses now for that tranche. And we wouldn't, even if we said we want 100 extra staff nurses, we wouldn't be able to get 100 extra staff nurses anyway. And we are already in areas, so for example, where we have 2 respiratory wards, that's already within the run rate, and it has been for the last sort of 18 months, and we continue to recruit. So I don't think there's any risk in delaying it till September. In fact, I think it's a positive because we might have more idea of how we're managing electives, how we're going to do red versus green in the future, and how the capital developments are going.
Yeah, thanks very much, Karen. So our chief nurse is inviting us to note progress and to expect a detailed report in September, which may indeed include further detail that would have been of use anyway now. So it's helpful that. Are there any questions or queries of Karen there, please? Are we content to note that? I think we are. Yeah, that's great. Thank you very much indeed, Karen. I'll just reverse now back to into quality. Karen, may I stay with you, please, in the first place for item 10, quality account. And obviously you're asking board of directors, and I guess Ray as well, to approve this account. Is there anything you'd wish to bring to our attention regarding that? And do you want to hone us in on what we need to be thinking about, please?
Thanks, Chair. I'm not going to go through any of the detail within the account and the performance because, of course, we've seen that throughout the year at various committees and have looked at that. So the main points to note are this. This is the quality account. You know, 80–90% of it is prescribed in how we write it. So it doesn't always read great in parts, and there's nothing we can do about it. The other bits to it are the appendices, which you won't have seen before, from Health Watch and the CCG. So we are required to write to our partners to ask them to comment on our accounts, and you can see they've done that. Particularly pleased that Health Watch have noted the work we've done around patient experience, and the CCG have also recognised additional stuff that we've done. So that was very kind of the CCG as well. So thank you to them. There is no need this year to get an audit opinion, as we've done in previous years. So we're in a position now where this is the final account that we can approve. What I do though want to draw attention to board is we have to define 3 priorities. Normally there will be consultation with staff, external stakeholders, but because of where we've been with COVID, that consultation hasn't taken place, or it has, but in a reduced way. So we are proposing that we roll over the 3 priorities from last year to this next year. But then learning from COVID and looking at the impact on lots of things over the last year, we were really conscious as a quality committee that there is something around equality and diversity that we need to link into this, and equalities or inequalities. So we have actually put in a 4th priority, which is quite unusual, that covers off work that we want to do around equality and diversity. And just to signal to that wider audience, you know, this is something we are truly committed on. This is, you know, one of our top priorities, and the more we can say that, the more people will hear us saying that, and the more they'll believe that we're trying to do something about it. So any questions, please, or Ray may wish to comment.
Yeah, thanks very much indeed, Karen. Thank you. Ray, do you have anything you'd wish to add, please?
Yeah, just a couple of points, Max, if that's okay. So yeah, thanks, Karen. I think obviously she summarised it very well. I think just to recognise that this is always a big piece of work. It's the first time I've been involved with it, and I think to do this at the time we've been in has been a real challenge. I think the timescales have been really tight. So I just wanted to put on record my thanks to all those involved, obviously Jackie and Laura, but particularly to Judith Connor and Leanne Elliott for all the work they've put in and having to do a lot of cramming to pull all this together. Very pleasing, as Karen said, to see the feedback from Health Watch and CCG, which I think were really very positive. So yeah, I think that the finished product is probably as good as we could have got it, given the circumstances we've been under. So thanks to all involved.
Yeah, thank you, Ray. Thanks for that additional information. That's really helpful. And Ray or Karen or any other exec colleague, could you just help me with, so if we've got 4 priorities in the coming year in terms of quality, I know there are other things, of course, I know, but what we're saying in terms of quality, we're going to improve the management of deteriorating patients. We're going to improve patient experience. We're going to keep reducing stillbirths, and we're going to advance equality, diversity, and inclusion. Wonderful. You know, nobody, I'm sure, could really object to those 4 priorities. May I ask what the intentions are in terms of determining a baseline number on those, and how we're progressing, and how there might be a kind of constant eye on what we're doing there, and indeed how board might be advised on that. So have you had the chance to think about the way in which we'll take those forward, please?
Yes, Chair, and I'm sure Ray will chip in as well. So we want to be have all smart objectives, really, because there's no point making some fluffy statements and not having anything to measure it by. So, for example, the maternity indicator around stillbirths, we will continue to monitor that as we do, and we're hoping to see a year-on-year reduction as we are doing. But I am sure we will, when we provide the narrative next year, put in more about maternity and talk about the OMS and the work that's happened there. From a deteriorating patient point of view, there is a group that looks at that. It reports into the Patient Safety Committee and in turn to quality. And they are setting the priorities, and it will be around sepsis and SJRs and all sorts of things to see where we can impact and reduce those numbers. Closely linked to the command centre and the rollout of the deteriorating patient tile as well. Similarly for EDI, I was quite I was quite clear, we were quite clear at Quality Committee to say, we don't want to put in that we're going to hit the EDI standard or the WUDES standard, or, you know, so many percentage, we'll see a percentage increase in senior managers, because actually that's not that meaningful. So we really wanted to work with, sorry, it is very meaningful, but we're already measuring that somewhere else. And we want something that really means something to our patients now. So again, we're going to look at some bespoke indicators around EDI to show that it's making a real difference. And that, I think, will be around listening to patients and really working in partnership and doing that more, similar to the model we've done in maternity. Ray, is there anything you want to add?
Yeah, just you're right, Max. Some things are easy to measure. So stillbirth rate is a number, and you can see that. But some of the other aspirations are harder to measure. So we have to be kind of smart and adaptable about different ways and innovative ways of looking at some of the different aspects there. There are various things that are going to be restarted this year, such as the patient outcomes group, which could be really important in the improving patient experience work. That's been put on hold largely because of COVID. And we've advertised and had several very good applicants for the Associate Medical Director for patient outcomes. So hopefully we'll be able to appoint to that role very soon. I think we've got interviews next week or the week after, following Paul Smith deciding to step down after doing great work in that for several years. So I think there are some challenges here, but obviously they're important challenges, and I'm sure during the year we'll rise to them with the work that we're doing.
Great stuff. Okay, thank you both, Karen and Ray. And I'll just open up for any questions, thoughts or comments. But obviously we're being asked to approve the quality account, and of course therefore everything that sits in there, for example, in terms of what our quality priorities will be, etc. And we've heard the way in which there'll be a close monitoring of that, and I'm sure the board will be cited on progress, because I guess within those 4 priorities there'll be some good news stories, won't there? There'll be some new initiatives that people think of and start to promote and advocate, and it'll be good. And we hear sometimes data can be more difficult than others depending on the on what we're looking to measure, the metric. Okay, so are there any questions, queries or thoughts? Are we content as a board of directors to approve our quality account? Terrific to see the endorsement, of course, of Helen Hurst as CCG CEO and Helen from Healthwatch as well. So that's great, that independent view. And I think that is unanimous support and approval of the quality account. So thank you, Karen and Ray, and best wishes to you both in really, you know, working those through and promoting them and getting people on side. So that's great. And if I may, I don't think there are any further points on that. Karen, are you content with that? Yep. Yep, that's great. And so shall I move to item 11, Ray, which again is a terrific paper, by the way, produced by the guys over at the research unit, I guess. So certainly people I'm sure have had the chance to have a look at it, Ray, but is there anything you'd want to bring to our attention? I think you're asking us to note the great stuff that's going on there.
Yeah, taken as read largely, Max, but just a couple of things to raise. So I think following the it doesn't feel like the reduction in COVID at the moment, but the supposed reduction in COVID, which we should be experiencing now, the priorities of the research institute have changed back to a little bit more business as usual. So they were asked to put on hold a lot of the research work they were doing in favour of COVID-related work. So that requirement has gone away. So they are continuing to upscale some of their previous work that they're involved with, while still carrying on with the COVID-based research. So they're still involved, for example, with the Novavax trial, which is going to carry on until the end of the year. I think there's a lot of detail in here which I won't go through, but just to make you aware, they are in the process of developing a new research strategy. And I think the other thing to note is that the CQC are formally going to be looking at research, and so that will be evaluated along with other aspects of the work of the trust that the CQC normally do. So I think that's a positive thing, because it's raising the profile of research and actually recognising how important it is. A paper is great, and it's nice to look at that, but I think to actually have the people involved as well is really positive. So this is a regular report, which of course the board receives, but we have invited members of the Research Academy along. So in September, somebody will come along to present one particular aspect in a little bit more detail. And then John Wright is going to join us, I think, for the November's board meeting to talk a little bit more widely, perhaps, and take any questions about the sort of wider aspects of research within our place and within our trust. So I think it will be good to actually see some faces from the Research Academy and actually take any questions.
That's great, Ray. Thank you very much indeed. And yes, I noticed the link to the CQC well-led domain in relation to research that's mentioned in the report. So thank you. And I guess directors, fellow directors, it's an open invitation, of course, to any of us that might be particularly interested in those matters that are under research locally at the moment. Should we wish to promote, advocate, get involved, engage, speak with partners, etc. regarding that work, it's all there. So really useful reports and some terrific messages there, I think. We're being asked to note it. May I ask whether, did anybody have any questions, queries, or requirement for further detail, please, about anything that's been reported or seen there? And perhaps you join me in thanking Ray and the research team, actually, for opening us up more to the research work that's going on in our local area. This is great. This is great to see this standing item of research activity, and as Ray said, to actually meet and hear in a little more detail about the particular work will be great. I suggest helps us act as more effectively as a board as well, because of the work that's going on there. So, yeah, that's great, and I think we're all content to note. So, thank you very much, Ray. I don't think there's any questions arising from that. It's a great report. Thank you. Okay, so I'll skip through. That was at 11. So I'll just go now to item 15, having dealt with 12, 13 and 14. I suppose I should just do Pat the courtesy of recognising that we've dealt with all people issues there, Pat, and just check whether was there anything you wanted to bring to the Board of Directors' attention in relation to people, please. We've had the 3 items, the E&D Council update, disability quality video and strategic staffing review. But Pat, was there anything further you wanted to bring to our attention on people?
No, there's not, thanks, Matt, because we had a detailed discussion and report at the Regulatory Committee last week. Thank you.
Yeah, no, thank you, Pat. That's great. Okay, thank you. And so we'll go to item 15 then, and just offer thank you. Well, thank you first, Barry, for the production of the report from the Audit Committee, which I've read, and I'll just invite you to bring to our attention anything you think that we would wish to, or simply to advise us if it's a matter of simply noting the assurance received from that. So, Barry, was there anything you wanted to raise in relation to your report from the chair of the Audit Committee, please?
Well, as you've seen, the report summarises the key matters dealt with by the Audit Committee in its meetings on the 3rd and 8th of June, fundamentally leading to us being able to recommend to board the approval of key year-end accounting and reporting documents. The report was shared with Matthew before I submitted it for circulation. Matthew seemed happy with it, but I don't know whether Matthew has any comments to make, or alternatively, or in addition, if anyone has any questions to raise about the report.
That's very helpful, Barry. Thank you. So, Matthew, just do the courtesy of an opportunity to speak, should you wish, on this?
No, I don't have anything further to add. I think it's a good reflection of the meetings that took place throughout June.
Yeah, okay, that's great. We're asked to note and derive assurance from this report. Does anybody